Where's he? How are you doing? I kind of like that too.
Good morning, everyone. I'd like to call the meeting of the Health Policy Oversight Committee to order. And just like to ask for a motion on the approval of the meeting minutes. They've been distributed.
So moved.
Move to minutes be approved. All those in favor say aye.
Aye.
Opposed? And motion carried. Now we've got some time for opening remarks. Once again, Representative Heath is not able to be with us this morning, so Bill Bryan is going to take his place and be my co-chair this morning. I know that we've had a little bit of a rough time here lately with the managed care transferring over to United, and I'm looking forward to some of the comments on how we're going to try and make things work. And I'm glad that we have folks here to help us out on that. We're going to have on the agenda, we're going to have the Department of Human Services with the managed care update, and then we're going to have the managed care ombudsman program, and then at 11:45 we'll have a break for lunch. Come back at 1 p.m. I'm going to have the committee discussion with the managed care organization representatives, and then we'll have time for public comment at 2 p.m. We'll have a half an hour for public comment. If you're if we run out of time, we'll try and have, I think, limited to 5 minutes again this time. And if we don't have enough room, we encourage you to submit your comments in writing, and then we'll be distributed to the whole committee. Or you can do that if you don't want to get up and talk as well. We're going to have a committee discussion at 2:30 p.m. And I'd ask that we don't make any motions until then. That'll be a time for us to discuss what we've been doing. And if we need to take some action, we'll try to do it at that time, okay? So then adjournment is scheduled for 3 p.m. Representative Friday,
Thank you, ladies and gentlemen, for being a part of today's hearing. I also want to just let you know that Representative Heaton sends his regrets. He wishes he was here, and I am sitting in for him as co-chair on the House side. And in your packet, we have the Oversight Committee rules. We have a number of the reports that we'll be hearing about today. And so please draw your attention to those pieces. I also am excited, I guess is the word, I don't know if that's the right use of the word, but I'm excited to have some conversation around the current transition, the current issues that we as legislators have been receiving by email and a variety of other ways, phone calls, to have some of those discussions as well with our presenters. I would ask that if you cannot hear us talking today in the back of the room, you'll have to let us know that with a raise of the hand or something. And this, again, remember that the public time is at later this afternoon, so if for some reason you can't be here, I've had a couple of you notify me that you can't stay that long, not legislators, but those of you who want to talk from the public, please submit what you have and what you would like to deliver to us so that we get that on record. With that, thank you for being here, and I look forward to the rest of this day. Thank you, Mr. Chair.
Okay, I believe at this time we have no further opening comments. I'd like to ask the Department of Human Services to come up and give a Medicaid managed care update.
Good morning. My name is Jerry Foxwell, and I'm the Director of the Department of Human Services. I'll keep my piece short today, primarily introduce the new Director of Medicaid for Iowa, and then he can kind of give you some update, as can my Deputy Director, Mickey Steer. Mike Randall was previously the Director of Medicaid in Kansas. He has formerly served in the United States Air Force. He has a bachelor's degree in accounting and an MBA as well. And so he has a great finance background, has great experience in Medicaid as well. I can tell all of you that I'm very, very pleased with adding him to Medicaid. He's just a great opportunity for us. I know he was sought out by other states as well, and we're thrilled to have him. He's hit the ground running and has been working real hard. He came at a time with a lot of transition, as you'll be brought up to date on, and has really begun doing just an exciting, really good job already. And so I'm going to turn it over to him at this point to start giving you some idea of what's going on.
Good morning. As Director Foxova said, my name is Mike Randall. I have spent the last 5.5 years as the Director of Medicaid in the state of Kansas and the Division Director and Finance and Informatics Director for Kansas as well. I take this as a great opportunity. I'm extremely pleased to be here. I look forward to working with you and other stakeholders as we move forward in managed care. This is the start of week 3, so I have been here 2 weeks, and as the Director said, it is an exciting opportunity for me, and I really do look forward to working with all of you. You know, with managed care, when you take a look at managed care, there's nearly 47 states that have some form of managed care, and more states at this point are moving their long-term support services into managed care as well. And one thing that I'm going to focus on, really am committed to with managed care, is that we need to make sure that the program is sustainable. You know, one of the things that we always look at in the managed care environment is we want to make sure that the program is sustainable so we can continue to provide those services for the members. And that's the most important thing. We want quality outcomes for our members. We want to make sure they have access. But we can't really do that unless we have a sustainable program. So that there is why managed care, in my opinion, is the way we move forward with that. At the same time, you still have oversight. You have to make sure that those quality outcomes are being met by those managed care organizations, that individuals have that access. So I'm going to give you some updates on some of the things that have been going on. I'm not going to read all these to you, but that's probably what I would have to do after 2 weeks here. But I have been involved in a lot of meetings and the transition discussions, and then the Deputy Director will absolutely fill in and help me if I don't have an answer for your questions. So we'll go through a few of these, and I'm not quite sure the protocol. I'm assuming that after we're done, we will be able to address any questions that you may have at that point. So really what I want to start with is kind of taking a look at the CMS transition. As you know, the contracts with AmeriGroup and United Healthcare have been signed. There's Amendment 2 and Amendment 3, which have been approved by CMS. Amendment 2 really looks at contract language updates, kind of take a look at rates update. Amendment 3, there's contract language updates, looking at managed care regulation changes. As many of you know, part of what we're dealing with in managed care all across the country in CMS is what they call the mega rule. That's the new managed care rule. There are a lot of components to that, different implementation and timelines, so as those dates come due, we have to actually amend the contracts with the MCOs to make sure we're in compliance with that new managed care rule. Once AmeriGroup indicated that they did not have the capacity, one of the first things that we did with respect to the capacity concerns, we reached out to CMS and really got approval from CMS to what they call suspended choice at this point. But really, as we move forward with that, that is temporary. We understand that choice is important, as does CMS. We also anticipate that CMS will be issuing the State of Iowa Corrective Action Plan relative to that. And we've been working very closely with CMS, addressing the capacity concerns with AmeriGroup as well as working with AmeriGroup. AmeriGroup Iowa continues to serve the Iowa Health Link members who are enrolled with AmeriGroup prior to the announcement of AmeriHealth Caritas withdrawal. But like I said, choice is a key part of managed care, and in the future, members again will have that choice with the MCOs, which ones they would like to choose. With respect to the update on the RFP, or the request for proposal, as you probably are aware, the department released a request for proposal to recruit an additional MCO to coordinate care for the Iowa Medicaid program. Again, we're committed to working with the existing MCOs and then bringing on another MCO so we can continue to move the program forward. As I said earlier, there are about 47 states across the nation, plus I think DC, that have some form of managed care. But when you probably heard the saying before, and I've heard it for 5.5 years, and never really understood until probably 3 years ago, but there are 56 different Medicaid programs across the country. Territories have their own Medicaid programs too, so that's why there's more than 50. And DC has theirs as well. But if you've seen one Medicaid program, you've seen one Medicaid program. They're all very distinct and very different across the country and across those territories. But once we award that MCO, there will be readiness reviews that will take place, but it's also very important that we ensure the MCO also has the policies, the procedures, we have the oversight in place as we move forward with that particular RFP, bringing on a third MCO. The department is evaluating both United Healthcare and Amerigroup's provider networks. Obviously, access to care is extremely important, and network adequacy is extremely important as well. Iowa has some of the same concerns that we did in Kansas with respect to access, especially in rural areas. Those are some challenges that we face in Kansas, and I'm sure it's probably an opportunity here as well in the state of Iowa. The states are very similar with respect to that. We are paying close attention, and particularly to some of those long-term support providers, behavioral health providers, hospitals in rural areas. So we want to make sure that that access to care continues, and not just access to the care, but access to quality care, which is very important as well. We're looking at the, as we ramp up for capacity with the Amerigroup, it doesn't really, not just the provider networking adequacy that we're looking at, but you know, there are also call center staff, utilization management professionals, so some of those internal individuals that really, from an operations perspective, to make sure that they're capable of providing the services to our members from that perspective and not just network adequacy. Members who were previously enrolled with Amera Health Caritas and chose to enroll with Amerigroup in November will be covered through the Iowa Medicaid program. As many of you probably are aware, there's approximately 10,000 of those members that were transferred to fee-for-service, and they will be, those services for them will be provided through the fee-for-service delivery model until such time that they'll be transferred to Amerigroup when that capacity has been provided by Amerigroup. DHS is working to provide continuity of case management during the transition of those members from American Health Caritas. There were approximately 1,750 members in HCBS that were transitioned to the fee-for-service. And really any case management entity that provided those case management services for fee-for-service was contacted to see if they would continue with those members during that transition. So it's very important during that transition to continue that care and care management and coordination and care for those members that were transferred. Current case managers are entering services plans into the DHS system. IME is assisting DHS case managers entering service plans, so we want to make sure those service plans are entered into the system. That's important because until those service plans are entered, then you have those challenges potentially with providing services from a billing perspective that won't be authorized. So we've got to get those services and those plans of services entered into the system. The final update I'll give, and then I'll ask the Deputy Director if she has any updates that she'd like to provide as well. I understand that the LSA House File 653 directed the department to move to a tiered rate system. We've done that. I believe it was effective December 1st. Implementing tiered reimbursement rates will better align the reimbursement rates to each individual's needs. And for those supports and services, IME established a tiered system of reimbursement for the daily supported community living, day rehabilitation, and adult daycare. The tiered reimbursement rates are designed to assign a standard rate based on the individual's need. And I understand that that is not immediate, it's a transition period, so I believe it's in a 3-year period until it's fully implemented. So it gives some time for those providers to adjust to the tiered rate system. With that, is there anything else you'd like to add?
I don't have anything at this time to add, unless there's some additional questions we can follow up with on statistics in terms of what we're looking at. I do know with some of the network adequacy, we are watching the statistics. I know that we have had some good contracts from United Healthcare in terms of the Mason City area as well as the Dubuque area, and really making sure that they are aligned right now closer in the 90 percentiles in terms of their adequacy for our long-term services and supports, which is very, very important to us. The other thing is you may question how many files and what has come over from Amera Health. All service plans, level of cares, and status on all of our members was data transition. We continue to have weekly calls with AmeriHealth. AmeriHealth will continue to be in the state till 11:30 of 8-10 to continue to ensure that our providers are paid. In addition to that, they will manage a call center for us for member services as well for some questions with member services and concerns. The other thing that we have done with all of the plans is we have an early morning debrief during the month of December, and then we were having weekly or daily calls with all 3 plans. We continue to move those through down bi-weekly with the Mera Group and United Healthcare. Key to that will also be is our member liaison. We have a member liaison dealing with what we call high-risk, high-needs members. And we meet directly with her and key members that are in transition or have questions with transition. In addition to that, we also are managing and making sure that that continuity of care is there. So one thing that United Healthcare has been doing, and they can speak more to this afternoon, is they have been hiring quite a deal of case managers. They are also hiring case managers from our DHS Targeted Case Management Department. As they hire those case managers, if those case managers move to United in a case manager's role, and there are members that are currently with AmeriGroup, those members can choose to move immediately to United to keep the continuity as well. So that has been one of our biggest focuses and one of our bigger conversations with our members and our strategies is our LTSS members, as well as also monitoring some of our behavioral health strategies that are in process. The last one I'm sure that's going to come up this morning, so we will talk about it briefly and then again work through United on that, is in our contract negotiations and our ongoing work for the state on sustainability. We're looking at all programs and all services and where we can gain efficiencies and where we can see duplication, giving our plans the flexibility to bring in new models and new methodologies of doing things is in our contracts. Contract Amendment 3 specifically speaks to chronic health homes, our ACOs, and the MCOs. And at some points in time, we may have more than one case manager, 4 case managers, depending on how it's laid out. That contract amendment gives us the opportunity to look at how we're doing that and how we can maintain continuity of care for members, how we can ensure those programs. And I know you guys have been receiving an awful lot of calls and texts regarding the integrated health home. As long as our MCOs have a plan that they can outline to us in terms of meeting the state plan amendment to meet those needs and those service requirements from the members, we are working on those. Now, I think things have, definitely will want United to speak to some of that more this afternoon. So those are just a couple things I thought that I would give you a line of sight on.
Okay, thank you. I guess at this time I've got a couple questions. And so you mentioned Director Randall, or I guess, what's the right term? Mike. Anyway, Mike,
Director
it's nice to meet you and welcome to Iowa.
Thank you. I appreciate that.
And you mentioned that choice was something that's really important, and of course now with the situation we are, until we get a third MCO, do you anticipate that AmeriGroup will be able to start taking new patients before that time? Because we're scheduled for, what, a year from July on that?
Oh, absolutely. It's the CMS, like I discussed earlier, in working with CMS, and they've been very good partners with the state of Iowa with respect to moving forward with this and transition. They understand that. But as I said, there will be a corrective action plan that they will be providing to us and giving to us, and we'll have to address those concerns in that corrective action plan. But we're not waiting until the RFP is done and we select a third MCO before that choice is resumed. We're looking at spring of next year in which to work with the AmeriGroup and moving forward with those members. So it's not a long-term assignment to the fee-for-service. That's not the intent of that.
Okay, thank you. Senator Mathis.
Yes, I do. Again, welcome to the State of Iowa Director.
Thank you.
I'm going to bring the microphone a little closer. I'm going to kind of start at the top. You mentioned that there's managed care in several states across the nation.
Mm-hmm.
You're aware we had managed care in Iowa with Magellan for a very long time.
Mm-hmm.
There was a lot of data to mine from that, and I'm not sure if any of that data was actually used in the formulation of the models that we have now. But I would encourage you to take a look back and see what worked with Magellan and see what didn't work. Yes, it was a bumpy road when they started working with Magellan, but it seemingly smoothed out after a while, unlike what we've been experiencing. And we've been watching Kansas. It hasn't been an easy go there either. It seemed like you were about a year and a half ahead of us, or 2 years ahead of us.
I would say we're about 2.5 years ahead, absolutely. And you're exactly right. In Kansas with CanCare, they started the program January 1st of 2013, and it really was all services, all populations, so there was no transition. So January 1st, we went to bed December 31st, 2012, fee for service. We woke up New Year's Day, and it was managed care for those services and those populations. So you're absolutely right. There were some challenges that we had to overcome.
I won't ask you what you learned and what we can garner from that. That might be another situation for another day. That's a long conversation, but we hope to, once the legislative session starts, have some conversations with you in that regard. The CMS transition, you said that CMS approved it. Do we have that in writing? Do we have formal approval of that?
They don't have to approve anything. Basically what it is, Senator Mathis, is our 1915B is the managed care waiver that talks about choice. We alerted them that when AmeriHealth transitioned and AmeriGroup didn't have capacity, that we would not be able to offer choice. They didn't have to approve it. They will put us into a compliance plan to get us back into choice. So they are aware we're out of compliance. We have two choices. One is that we have to get AmeriGroup to be able to go to capacity, and the issue with capacity was the rate at which we had to move the members from AmeriHealth to AmeriGroup. That's right. The second is we also have to have an RFP to bring in another plan. So those are two pieces, and then we had to have a contingency plan for those members that AmeriGroup that had made a choice in November, that when AmeriGroup said they couldn't take the members in December, we would have to then have an alternative, and the alternative was to move the 10,000 into fee-for-service. So those were the three things that we work with CMS. They will give us a formal compliance letter to tell us what are your strategies, and I just kind of outlined the ones that we're working on right now with them. We have we were having daily and now weekly calls with CMS on this.
And so that's what Director Randall was referring to as a corrective action plan.
That's correct.
Okay,
it's a corrective action plan to your 1915B waiver, in which we have to be able to demonstrate that members have choice.
And is that a public document, your corrective action plan? It would have deadlines and metrics on it,
We don't have it yet. As soon as we receive it, like everything else with CMS, I'm pretty sure it's transparent.
And so that's what you're waiting for. And in a way, would you say that that's an approval?
I wouldn't call it approval. I would call it a corrective action plan to pull our waiver back into alignment with what's in our waiver.
I would say they agreed to work with us to ensure we're in compliance with the waiver.
And what if they don't accept your corrective action plan?
They will work with us so that they can accept. I mean, we're working with them daily. I mean, if you guys know this for 2.5 years, anytime CMS and us, I mean, we're just continually working that if we don't have something where they want it, we bring it back. It's just like we do with waivers now. They'll ask you questions, you need to go back and answer those questions and have dialogue and continue to have ongoing dialogue.
All right. The RFP, are you looking for one or several? Will you be selecting one, or?
I don't know if I can answer that. I think what we'll do is we'll see the responses that we get, and we'll select the appropriate MCO or the appropriate vendor based on their responses and the criteria that's outlined in the RFP.
Back to the corrective action plan. In access to care, I think originally it was 30, 30, 60, 60. So 30 miles, 30 minutes to a primary care physician, 60 miles, 60 minutes to a specialist. How are you fulfilling that now? How are you relating that to the corrective action plan for some of the more acute patients? Where can they get their basic services?
We're still using that formula. It's still the same network adequacy standards that was required. Those have not changed. So what we do is we run network adequacy reports on AmeriGroup and United. But then keep in mind, in the new managed care regs, all providers have to be enrolled with Medicaid initially. So those 10,000 would have all of the providers for us in fee-for-service. So fee-for-service has those requirements. So it is the same standard regardless if they're in fee-for-service or in managed care. So we monitor that, and we have statistics on the monitoring for United and United as well.
Well, we're talking about fee-for-service. I think Director Randall said 10,000 fee-for-service would go back to AmeriGroup. I didn't know if that was misspoken or 10,000 that are now in fee-for-service would go back to AmeriGroup. And how will that work?
Well, I believe that, and Deputy Director can, correct me or add to this, those are the members that selected AmeriGroup through that process, and since the capacity wasn't there, then they went to fee-for-service. So once the capacity is there, I haven't seen a timeline, but there'll be a transition to move those individuals. I don't believe you would take all 10,000 at once and move them. So I think there would be a plan in place to transition as AmeriGroup gets the capacity and move them to AmeriGroup at a certain time, which I believe is spring of 18 is the timeline that we're looking at.
Sounds like a slow drip. All right. And then we've been receiving, I think, all of us, because I noticed on the email lots of addresses about integrated health homes. When that was established here in the state of Iowa, DHS was a driving force in creating health homes. Jennifer Vermeer was still here, and it was an innovative idea that ran parallel to really what many of the hospitals and healthcare directives where they were going. And so it was embraced, I think, enthusiastically by both pediatric and adult. And it's something that, when we talk to the MCOs and they would like to get to innovation, this is something that is very innovative. And what I'm seeing in my emails is that it's being blown up. That it's not being recognized or maybe being placed on a pause button right now by United Healthcare. And the providers feel that it's something that really worked. It was something that was actually going along smoothly, and now there is this disruptive effort behind it. It's like whiplash. You've asked the providers to help create integrated health homes, and now we're going backwards with this. And so now this is something, again, I think the last meeting I talked about the roller coaster ride that everybody's on with this, but it just seems like providers have built up the clientele. They have gone along with the contracts in terms of how many nurses that they have to have, how many peer support specialists they have to have, and all of that to run integrated health homes properly, according to what IME and DHS prescribed, and also what initially the MCOs wanted to have happen, and now it's kind of blowing up. What are we going to do to fix this, to get this back on course, to come to some type of compromise, to make sure that the clients who are actually receiving great care continue to get that care? What's going on in this arena?
So let me just back you up just a little bit if I can on that. So in April of 2015, we put on a full-time staff person to watch the integrated health homes at our health homes. We, the state, and all of the MCOs went out and surveyed the integrated health homes as developed and designed by the Magellan contract, and it was purely a Magellan model. They were out of compliance, several of them, with some of the state plan requirements. We continue to work with them almost 2 years now with our full-time staff. There are bi-weekly and or weekly calls with the MCOs and our integrated health home partners to try to move them towards those standards that are in our state plan. There is duplication in some of those services between the care coordination that our MCOs are bringing. And this happens, and Mike can speak to this in terms of even what you saw in Kansas, but this happens as we evolve further into managed care, where we start seeing that there is duplication of services and how we can align those. What our requirement is that if a plan so sees, and we also now have ACOs that have also moved integrated health home and chronic health homes into their model of delivery. So you're seeing a lot more growth in terms of the care. It's mainly care coordination. It's mainly that wrapping those services around our members, our serious persistent mentally ill members and our chronically ill members. ACOs are starting to replicate a lot of that as they're building and going to risk on value-based contracts. So are the MCOs as we're holding them greater accountable. Our request in our contract amendment 3 is that the very principles that our MCO, the very principles of our integrated health homes have aligned in our state plan have to be accounted for and maintained to ensure the members' stability in that program and in those services. How the MCO designs the model or modifies those models has to be worked with the state so that they meet the state plan requirements. And we have asked that of United to show us how they are doing that. United has, since operations, and again, I don't want to speak for United Healthcare, have had somewhat of a blended role with their care coordination in our integrated health homes. This is not new what United is doing, but they're doing it on a different scale. So they can speak to that, and we can also help them through a transition with the state plan and what they envision moving forward with our integrated health homes to meet the requirements that we have in the state plan.
Are you politely saying this is a bloated, ineffective plan that's just kind of gone out of control because Magellan didn't have any oversight on it?
I'm not saying that. I'm saying that when we step back into managed care, one of the things we really started to do is look at all of our programs, all of our services, and say, I mean, we could pick on transportation. I don't want to pick on anybody, but I mean, we could look at transportation. We knew that when we transitioned transportation, we had some issues with transportation. We stepped back as a state, looked at the requirements for non-emergency transportation and said, what do they have to provide? With integrated health homes, chronic health homes, you have integrated health homes, chronic health homes, you have the accountable care organizations, and you have our MCOs all doing case management. You could potentially have a member who is with an MCO getting care coordination, but also enrolled in an ACO getting care coordination, and that ACO may have a chronic health home nested within it. That member is getting 3 different case coordinated services for that person. As the managed care plan starts looking at level of cares and service plans, they may say, you've got 3 people. The member's like, well, who do I pay attention to? I've got 3 different people helping me with my care. Our goal is to work with the state plan amendments that we have, our MCOs and our providers, to say, what is that model going forward and how does that work? And that's why we have a full-time integrated health home staff member dedicated towards helping us understand if we're in compliance, if we're not, having weekly meetings with our integrated health homes and our MCOs, because we are literally working through a transition.
Well, one more question, and I apologize for. It almost sounds like we're throwing the baby out with the bathwater, though, Mickey, and because I'm thinking not every single client or patient is like that. They're not getting all of those services. I think what you're saying is the extreme example of it if someone has 3 or 4 case managers on something that's duplicative. And I understand that. I understand what you're trying to do is take a look at that holistically and say this isn't necessary. These services are already done. So I hope that you would continue to not take a blanket approach to this, and that it would be more of an individual analysis on case-by-case basis.
Yeah, absolutely, and what that plan is, I think United needs to speak to how they're looking at that, and again, the state will be actively involved. That's why we have a full-time dedicated FTE to integrate health homes and health homes to really look at how those models individually move and generate. Last thing we want to do is really, we do need to keep it member-focused and on an individual basis. Yes, ma'am?
Thank you. Sorry.
Next up is Representative Joel Fry.
Thank you, Mr. Chair. To follow up with a few more questions about the IHAs, I want to focus on more from a geographic standpoint across the state and where IHAs exist today, where ACOs exist, and how this transition geographically to make sure that we don't have people left out in the dark of service. Would you please address that and how you're marching forward, making sure geographically we have it covered well?
I'll have a few comments, and I'll certainly let Debbie, Director, chime in since, again, starting week 3, but I do think that the integrated health home is extremely important with respect to access. I think, kind of going back to Kansas as well, that was a challenge with respect to rural Kansas, I'm sure rural Iowa as well. So I believe what we'll be doing, and I'm a firm believer in data. I really think data drives decisions, and so that's what I talk about when we really look at quality outcomes for our members, access for our members. There is a lot of data out there in reports that needs to be reviewed and analyzed to ensure that that access is complete. And that's part of what we'll be doing as well, working with the MCOs to ensure that that access is there for those members. Because it's extremely important that they continue, they not fall through the cracks, so to speak, with respect to getting those services, because it's a very important population with respect to the needs that they have. And so that we'll be working very closely with the MCOs, and as the Deputy Director said, a full-time member who does that analysis as we move forward with looking at integrated health home and the model as they move forward with bringing that into the United Healthcare.
So what we to the director's point is what we are doing is mapping out where our ACOs are. We know where they are. We know where our integrated health homes are, where there is that overlap, and having those conversations with our MCOs to ensure that there is network adequacy across the state.
How soon will that map overlap be available for us to see as well?
I'll go back and find out for you.
Thank you. Follow-up, continue the conversation just a little bit. I want to switch to capitation rates for just a moment in this conversation. And are capitation rates shifting and changing because of this shift from IHAs to ACOs? What does that look like within the context of conversations with MCOs?
I certainly can't speak to the detail of the capitated rates here in Iowa at this point, but typically what happens is, part of this is looking at reduction in duplication of providers and services that are being provided. So anytime you have efficiencies within the program or duplication that may be taken out of the program, obviously there will be a shift in the capitated rates as far as what you're paying the managed care organization for. But specifically, I don't know, but there will be an impact on capitated rates. And typically in a program, as you manage those efficiencies and implement those efficiencies, those capitated rates are somewhat reduced because those services are no longer being provided or provided already within the care coordination, which the MCO is already being provided the PNPM for.
So at this point, the verdict's still out on that discussion as to what that looks like as this shifts and moves?
Yes.
Okay.
But that will be certainly part of the analysis that we will do with respect to as we move forward with setting the capitated rates.
All right. To the discussion of communication about the shift in the IHA, or IHA to AC, IHH, sorry, to the ACOs. What level of communication are you aware of went out from United to providers from your perspective? And United can have a fair warning. That's a question coming from me later on in the day as well.
And I certainly don't want to address United's or answer for them. I believe that in discussions that we've had with United, I did express concern relative to the communication strategy that was implemented. So I really would like United to kind of address that. But the state, and we're working with United as we move forward with that. And that particular strategy, communication, is extremely important from both sides. So I think they'll be addressing that this afternoon.
I want to switch to a different topic for just a moment. And you mentioned the American Group and the 10,000 patients. We don't know the time frame yet. We're on a timetable, hopefully in March-ish, maybe spring, sometime. I'll put March out there. Actually, I'll put January 1 out there. How's that for pushing things along? With that being said, I want to talk about the CIS scores, the tiered rates, and for providers who haven't necessarily taken those CIS scores serious in the past, because it's been a long process to get where we're at with tiered rates. And what does it look like for those providers to be able to go back and change CIS scores, make them more relevant so that the members are in the right tier potentially, or maybe today they're not in the right tier because the CIS scores aren't relatively reflective of the care needed. What does that process look like? And what does a provider have to go through to get a new CIS score authorized?
I'll address at a high level, and I'm going to look to the Deputy Director to address more specifics, but I do believe there is a process in place. And first and foremost, you're exactly right. I think prior to tier rates, potentially the CIS wasn't probably taken seriously, or was just kind of, you know, going through the procedure, and it wasn't looked at. But now that the tiered rates are in place, and those tiered rates are based upon the outcome of that particular assessment, it's extremely important that that be completed appropriately, correctly, timely. But I believe there is a process in place. If there's someone who believes that they need an assessment to occur, a reassessment, because their needs have changed, or they don't believe that that assessment is correct based on the services required, the needs of the individual, that there is a process in place for that to occur.
He's exactly right. There is a process. So keep in mind there is care coordinators in place. If you are a member or a member's support system and believe that the members' conditions have changed, either they've gotten better or they have declined, that care coordinator can signal that they need a different assessment on the level of care and their CIS as well. We are encouraging care coordinators, family members, and care teams that when those CIS scores are being evaluated, that there's actively participation in those so that those scores can be adjusted accordingly, but it is based upon the member's needs and a signaling from a care coordinator that there is a change and the member's CIS score needs to be reevaluated.
So it's very appropriate as a legislator for me to be encouraging family members as well as providers to make sure the CIS scores are accurate and pursue the process that's in place if they feel that that CIS score doesn't match the patient's needs or the member's needs to fall into the right tier for payment.
That's correct.
Okay. I believe that's it, Mr. Chair. Thank you.
Okay, Senator Reagan.
So the appeal process is there for the CIS scores, is what you're saying?
The CIS score is
On November 29th, from Department of Human Services to us, said that they were working with the Attorney General's office to work through what is appealable.
I don't believe right now we have that appealable process worked through. What I am saying is that if you at this point in time believe that your members changed, get to your care coordinator and they can request a reevaluation of the CIS score. I have a meeting this afternoon on appeals, so I don't think that appeals process for that particular thing is there yet, but I will check on it this afternoon.
Because I was under the understanding it wasn't there yet. So, because I have heard many comments by people with great concern over that. Originally, when we started the managed care system, it was about accessibility and network adequacy, and that was one of the big reasons that it was pushed back, was network adequacy. So I'd say we're at a little concern now, and you're saying that corrective action is what will be outlined by CMS. So when did CMS know American Health was leaving?
Right after we were notified and we notified them, then we contacted CMS that same day. And it isn't about network adequacy, it is about the ability to offer choice. Okay. It's the corrective action. And
it's somewhat similar though.
Kind of, but then we're making sure through network analysis of both plans that they meet those same requirements.
And so when were they aware of AmeriGroup not being willing to take on those extra?
The Wednesday before Thanksgiving.
So they are comfortable with all of this and are working with a plan for this. Because as I recall, network adequacy or choice was a big reason that it got held off originally. So you talked also about sustainability, and welcome to Iowa. And
Thank you.
I think that's a big concern for many of us. And are you concerned more about the sustainability of the MCOs, or have you been made aware of great concerns, especially over what I've been reading with the integrated health homes, their concern of continuing to provide services across the state of Iowa with this change?
I think I'll take it up a higher level with respect to my particular, I wouldn't say characterize as concern, but what's going to be first and foremost in my thoughts as I move forward initially is that more or less concerned with the sustainability of the program overall from a managed care perspective. Because one thing that we have to take a look at is where is the program going to be in 5 years, 10 years, 20 years from now? We may not like it, but we're all getting older every day. And so as that demographic changes too, the need and the demand for those services, I think, is even going to grow and be greater as we age, because the primary provider of long-term care in this country is Medicaid. So, and that Medicaid, with respect to long-term care, that's very expensive. So I'm concerned about where we are 5 years, 10 years, 15 years from now. Can we sustain this program and continue to provide the level of services to those members that they need and have those quality outcomes that we look at? So sustainability goes far beyond just, you know, the 3 MCOs, the 2 MCOs.
Which I agree with you. I'm looking at providers across the state. We're all talking mental health. What are we going to do for mental health? What are we going to do for mental health? And I'm getting emails and calls from concerned mental health providers saying, we can't stay in business if this is the way the system's going to be run. We can't stay in business waiting and waiting for payments. We can't stay in business if we have to appeal and appeal. I think that there's a great concern out there about the adequacy that will be there, as you say, when we're getting older, and also for the rest of the population, for adequacy for mental health services. Let's take that in particular. And could you speak to that, how we're going to sustain the providers? And I'm from rural Iowa, so I'm deeply concerned about rural Iowa having those adequacies.
Yeah, I don't know if we can solve that particular issue here today, but it's a long-term issue, solution. But one of the things that I plan on doing as well in the next 30 or 45 days is I want to get out and talk to stakeholders, talk to members, and understand what those concerns are, specifically around rural Iowa and some of the providers and just the members too, so I can get an understanding of what those concerns are. There's always going to be some challenges with respect to rural Iowa, rural Kansas, so to speak, too, as far as delivering those services. And one of the things that you take a look at is what can we do from an innovation perspective, utilizing technology, different types of technology. One of the things that we moved forward with in Kansas Medicaid was telemedicine, taking a look at telehealth. How can we impact access to specifically, you know, psychiatrists in rural Kansas, because there's a severe shortage of that. So we're looking at pilot projects as you move forward with how can we implement that and utilize that technology. You know, we also have to take a look at, particularly when you look at sustainability of the services that are being provided. One of the things that I always look at from an efficiency perspective is want to make sure we're able to provide those services to the members, the appropriate services. So perhaps there are services that are being provided in a program that we don't need to provide. But what we do then is we do that analysis and say, okay, from a sustainability perspective, if we could remove those services or whatever, and I'm just, you know, looking at that from a long-term perspective, we add additional services or look at the different rates from a tiered perspective, whether you focus on long-term support services or long-term care or behavioral mental health. You know, that's why you have to have that efficiency in a program, that sustainability, that it's the right service, the right time, the right place. That's what you want to do with the managed care program.
And I appreciate that. One of the things that I thought about that we talked about, one of the things that was promoted with managed care was flexibility. And you talked about the right program at the right time. I look at all these integrated health homes that are doing, you know, really exactly what they say they are, integrated health homes, moving to ACOs and the physician, to me, is going away from some of that opportunity of flexibility, and also with you know, the opportunity that you have built relationships and really made a difference in people's lives. Because at the end of the day, this is about getting people healthier. And that's what I thought the goal was. And I'm greatly concerned that we are maybe losing some of that flexibility and with the MCOs, which that is what should have been the opportunity to have utilized. So I appreciate also the fact that we're talking also about case managers. You said that, and I don't know if it was you, Mickey, or you, about America Group would then be able to, if the case manager could be transferred.
Right, so I believe, and Debbie correct me, but if United were to hire a case manager from DHS and they were hired as a case manager with United, United then has agreed to take that caseload of that particular individual, so that continuity of care continues, and those individuals don't have to look for another case manager.
And that would be another opportunity maybe you could look at with the integrated health homes, because there are certainly case managers that have built relationships, and that would be another opportunity.
Okay, Representative Hedges.
Thank you, Mr. Chair. Thank you all for being here today. I guess my first question, I want to go back to the CIS scores. And if I heard you correctly, Mickey, you said that, did you say the providers could request a reevaluation? Is it a reevaluation of the score?
So if a member's condition changes and you believe that that CIS score is no longer meeting that member's condition, through the care coordinator, provider, family member can go to the care coordinator and we believe something has changed with our person, our family member or the member. We would really like to see if we can have that score reviewed. They are reviewed. I think it's an every 2-year process that the CIS scores are evaluated and updated for members regardless. But if they believe that they have changed, and this is not new, that if their condition has changed and warrants a reevaluation, that can be requested through care coordination.
Okay. I know a comment was made earlier that they didn't think that providers or whatever were taking those CIS scores, what's the word, maybe to heart or previously, but they are now that we've got the tiered system. Can you explain your rationale for that particular statement? I mean, because I know from a parent perspective as well, utilizing some of that information was used to develop care plans. So I'm a little concerned by the comment.
I mean, from my perspective, I think that, certainly the rationale as far as, anytime you have an assessment that there really is nothing that is, besides the services, I don't want to say that everyone's not taking that CIS assessment seriously. I think there probably were some that may not have moved forward as seriously or timely as they probably should have. And they should have as well, even without the tiered system, because the outcome of that particular assessment is what kind of drives the services that member is provided. But not only do you have that now, but you have a tiered rate that is dependent upon that outcome as well. So it's extremely important from both those perspectives to ensure that it's appropriately, timely filled out and move forward with that particular documentation.
Another question I have, this goes back to the integrated health homes, and I know you kind of said that there is a pause, I think, right now between United and what their plan was. But can you tell me when you were made aware of their initial plan to not at least service individuals under the integrated health home, and what the discussion was in regards to paying providers for the service?
So I think that we need to hear what United is saying this afternoon, if you will, and then we can follow up with questions. But I do know that United's model may not have transitioned as much as we believe it has, and they have been paying providers. But again, I think as soon as we heard and we started hearing some of these noises, we reached out to United as well and said, what's transitioning, what's happening, and give us some insight on what's going on.
So I guess my question is, when were you hearing those noises, or when did they tell you? Because I know from providers, they didn't hear till December 7th.
Yeah, it had to have been in the last couple of weeks.
So, okay. Yeah. My understanding as well is did they tell you verbally that they were going to do this, or did they do it in writing?
It was verbal, and we've actually asked them to come together with us and help us with, a stronger communication plan, and two, let's sit down and look at this and evaluate what their strategy is, and according to our contract amendment.
And is this a breach of contract at all? And if not, is it because they do have flexibility within their contract? And my understanding, it's not for the whole population of folks who are receiving integrated health home services. It's just about 5,000 of the population. Is that accurate?
I don't believe it's a breach in their contract. We can go back and verify that, but the contract gives them the flexibility to, as long as they're meeting the state plan amendment requirements, provide those services for us and show us a roadmap on how they're doing those.
And maybe I can help clarify that a little bit. I don't think it was a breach of contract. I think this was the issue that the Medicaid director told you. We had a communication discussion with United. And I think communication will be better in the future. I think particularly at the time of the transition, United had lots of additional new patients, and they didn't communicate as well as they should have communicated. And I guess I would say if that was their failure, better that than that they dropped care of patients. And so our Medicaid director did talk to them about the lack of communication that occurred relative to the international IHHs, and so I think that was a mistake. I think it was a ball that was dropped in terms of the communication. Again, I guess I'm not terribly surprised that a ball was dropped in communication relative to the transition that they picked up, and so I'm disappointed the communication wasn't as well as it was, but if there was a ball dropped, I'd rather it was communication rather than patient care. But they're here and will be able to explain to you what happened.
Well, I appreciate that, and this will be a question I will ask United this afternoon, again, so that they're on notice. But I have a lot of concern that if they haven't provided you the communication, and they're getting our taxpayer dollars, and they're not articulating that, but even more so, the fact that they are not articulating it to the individuals that were receiving the service. You know, providers were told, no, we're not letting the individuals know. And that's not just from providers in my area, they're from the hundreds of emails that I have received or talked to on the phone. And I certainly would hope that this committee would seriously look at increasing oversight if that's the type of response we're getting from these managed care companies. Thank you, Mr. Chair.
Okay, Representative Forbes.
Thank you, Mr. Chairman. Since we're on the topic of case managers and care coordinators, it was brought to my attention, and I have no way of verifying this or proving this, but I've been told that case managers, care coordinators are being bonused, being paid additional money above their salaries to work for increasing independence for people that are affected. And in essence, it's a reduction in services to these patients. Are you aware of the MCOs paying bonuses to case managers to reduce services to recipients?
No, not at all. We monitor that very careful, and if you can remember, key to this is the level of cares. So when a member's level of care changes, or there is a change to the level of care, those actually do have to go into the state, goes into Medicaid and Medicaid medical services area, and we have to review those and authorize those changes before they are finally approved. And that is where we have that safety net, if you will, in terms of our members and our members' condition. What we are aware of is moving members' payment, or moving members' care to what's called the Title 19 hierarchy of payment. So if you are on a waiver and you have services that should be paid by our state plan under Medicaid rather than by the waiver, we are moving member services in alignment with that payment hierarchy.
So you're saying if the MCOs would be bonusing or paying additional salary to caseworkers, care coordinators, that would be in violation of our contract. Would that be a fair statement?
Again, I'm not sure it's a violation of the contract, but basically if they're incentivizing things that don't help our members and we are signing off on level of care, again, we're approving all level of care changes, then we would definitely be having conversations with the MCOs. If we saw a huge change, a trend in level of cares, we would be monitoring those and having conversations if they come up and we see that. And we do monitor that at DHS.
I've been told by at least 2 different individuals that that is occurring, but I have no verification of that. But I think from the perspective of the state, if state money is being used to pay additional salaries to employees to work towards what they call increasing independence, which in essence is reducing services to Medicaid patients, I have a huge problem with that.
It's something that we will look at with the MCOs and understand, but to the Deputy Director's point, anything that, as far as an incentive perspective, our primary focus and our commitment is to the members. So if something is being done that is detrimental to them, that's not providing the quality outcome that we're looking for. In essence, what we're providing, that capital payment for that managed care organization to manage that care, then that's something that we would certainly take very seriously. Ultimately, we want to do what's best for the member and the services that are being provided and the quality of those services, and we move forward with that.
Well, I would ask the department to at least look into this, because if it is occurring, I think it's a breach of contract, and I don't know how you investigate that, but like I said, I've heard this is happening. I'm not sure which MCO, or multiple, but it's a very big concern of mine. Secondly, to Director Foxhoven, I know this is a little bit off subject, but CHIP, federal reauthorization of dollars to CHIP. I know we have enough money in the accounts to get through the end of March. Where are we at with CHIP, and can you update us on a contingency plan if federal funding dollars go away? What happens to these 70,000+ children here in the state of Iowa?
Well, as you said, we're luckier than most states. We're set until I think into April. If CHIP is not reauthorized, I think most of us believe CHIP will be reauthorized. I think it'd be a surprise if it's not. Although what's going on in DC is a little unpredictable right now, no matter who you are, I think. Right now, there are enough changes that we have to, hope for the best but prepare for the worst. And so we're trying to develop some contingency plans just in case. We're not real far along on those because we have several months, but it'll be a challenge. There's no question it will be a challenge to deal with that if it is not reauthorized. It's a lot of kids.
Thank you.
Okay, Senator Sheldon. Wait, I'm sorry, Representative Taylor before remarks, so we'll let Rob go first.
Thank you, Mr. Chair. Just a couple quick questions for you all today. First question is going to be directed to you, Director Randall. Thank you for being here today. We haven't had the pleasure of meeting officially yet, so welcome.
Thank you.
Tell me a little bit more about House File 653, which directed the department to tiered rates. And it gave up to, and your statement was it gave up to 3 years to go to to transition to the tiered rate system.
Again, I'll answer at a high level of what I have been made aware of the last 2 weeks, and then the Deputy Director can certainly fill in the detail where I either stated incorrectly or don't fill in the detail. But I understand that for the last several years that the state of Iowa has been working to move toward a tiered rate system, in the sense that from my understanding previously there were thousands of individual rates for the members, and it just really wasn't manageable to do that. So the legislature, with that particular House file, I certainly call it House file, provided the authority for the department to move to a tiered rate system. I believe there are 6 different tiers in that system. It's based on the assessment score of the system. Basically, it's based on the level of services that are required for that particular individual. So and I don't have the tier rates memorized, but you have a higher tier rate, obviously we get a higher per member per month payment. And it's one of those things, I believe, that was budget neutral to the state with respect to cost. But there will be some impact to some providers as they move forward. And I think that they wanted to make sure it wasn't an immediate, drastic, dramatic impact. So there was a timeline built into the file that said, okay, we will do this over the next period of time. And I believe that period of time is 3 years. So it's my understanding that state fiscal year 19 or 20 would be the year in which it would be fully implemented for those providers. So that would give them time to adjust their business model if need be, relative to those new tier rates.
Tell me what you know about, within that, the rehabilitation that's built into that model.
I will have to defer that to the Deputy Director to answer that question.
Okay, so in the House file, it didn't have the timeline. We put the timeline in because it's a third, and a third. A third that'll have a negative impact, a third that'll be neutral, and a third that'll see an increase in their rates. Daily SCL is key to the tiered rates in terms of what we have built into those tiered rates, as you will. So it is daily SEO that speaks to those tiers.
Well, the reason that I asked that is I wish we had 3 years for some of the organizations I've been working with and 4 over the interim, one of which was a day rehabilitation center in West Branch, Iowa. They were given 18 days to transition to the tiered rate model and got a 53% cut in their reimbursement rate. Now, to the department's credit, they're working very hard to extend that to 6 months. But to your point, Director, immediate, drastic, and dramatic changes make real impact to those organizations. And I would ask that you all be very conscious and aware of that when we make those transitions. Secondly, Director Randall, a question about CanCare. I know you're in Iowa, you're representing us now, but you said in 2013 all services and all populations were originally under that new model. Was there any modifications or changes that occurred from 2013 to now that we should be aware of and maybe take under consideration?
That's a very good question. You probably speak for a very long time. And let me clarify too. January 1st, 2013, there was a provision that we did let the IDD population delay for 1 year. So January 1st of 2014, the long-term support services paid for that population was not in managed care until 2014. Their acute behavioral was, but not the long-term support services. So to answer your question, and I don't want to spend a lot of time on that, but absolutely, I think that, one of the things that you look at in managed care, and when we went live with CanCare in 2013, there were challenges with respect to the system. I mean, it was a tremendous change, not just for the Medicaid member, but the providers, the 3 MCOs that are coming in. You're learning how to submit the bills correctly. Payment was extremely important. So, we had a lot of provisions in place to deal with that. One of the provider types that we paid particular attention to and was very cognizant aware of any drastic, dramatic changes was the long-term care providers in the nursing homes in the state of Kansas, as well as those providers that spent their time in the smaller organizations, the mom and pop, so to speak, with respect to those who provided long-term support services to the members. They were used to getting paid in a very short period of time. We had to transition that into a normal pay cycle as far as 30 days or more, or 30 days versus maybe 2 or 3, which they were kind of coming into the building and waiting for their check. So that was a transition as well. But I think as we move forward with managed care in any state, what you have to take a look at is and like I said earlier, I'm a very big believer in data, and data drives those decisions. And when you take a look at a managed care delivery model, there are certain things you want to see in the population. You still want to have the sustainability, you want to have those quality outcomes, but you want to start seeing certain trends in the delivery of those services. So, for example, there's a category of services that are monitored very closely, like utilization patterns. So if you take a look at ER, you want to see a reduction in ER utilization. That's why you have a managed care. You want to see a reduction in the inpatient utilization. You want to see a significant increase in the primary care physician visits because you want those members going to the primary care physician, getting those wellness checks. You want to see increase in transportation. So you need to kind of take a look at those utilization patterns, and are you seeing what you should be in a managed care system? And obviously, as we move forward the past few years with CanCare, you take a look at efficiencies within the program as well, as I talked about earlier. What services really aren't providing this quality outcome that you're expecting? So can we provide different services? Can we open up different codes? Can we increase the rate here and there, depending on what the outcome is that we're looking for? So you take a look at those things too from an efficiency perspective. But first and foremost, I think one of the most important things that we did, and I think we did it correctly, and I'm not saying it wasn't done correctly here, I'm just saying it's extremely important from a communication perspective. That's why I want to get out and start talking to the members, talking to the provider community, working with you and other advocacy groups, understanding exactly what their concerns are. It's very important from my perspective. Now, with that said, they may not like everything I say, and I may not agree with everything they say, but at least it's important to open that dialogue and have that communication. They can see my face, they understand who they can call, who they can contact. So I think that's extremely important as I move forward as well. And I could probably speak a lot more, but I do want to say one thing, Mr. Chairman. I do appreciate the opportunity to sit down. We weren't allowed to do that. We had to stand at a podium for like a couple hours and, sit there. Oh, absolutely. So I do appreciate the ability to sit down. Thank you.
Mr. Chair, if you'll just indulge me, I just have 2 more quick questions. Director Randall, you say efficiencies are very important to you, is that correct? Okay. Director Foxall, you kind of addressed this the last time that we were together, but again, if efficiencies are so important to you, what additional efficiencies can we find in a quadriplegic patient who's been in a wheelchair for the last 10 or 15 years? Under the MCO model, what additional increases can we see in efficiencies there? And before you answer that, I'll warn you, it's a loaded question.
Oh,
and secondly, when you're going out and talking to the populations that we talk to, it doesn't matter if you're Democrat or Republican, nonpartisan, it's summed up as this: there's a severe delay in payment and a severe denial of services that are going on out there right now. I have one hospital right now that told me last week that they have 4,000 bed days that they've not been paid for this year. That is unacceptable.
I agree with you, that's unacceptable, but that's something that I need to understand too. And I have no problem if you want that hospital to contact me, and we will certainly go through the process of understanding what the issue or challenge is. Now, to go back and answer your question, and I understand it's a loaded question. I'm sitting here before a committee. I certainly understand that. Done that for a long time. But, you know, I'm not a clinician, but one thing I have seen, as Director Foxhoven said, my background is finance. I like data, analytics. And sometimes I think that what occurred to me over the last 5.5 years, you spend a lot of time in a corner office, so to speak, looking at reports, understanding efficiencies, looking at statistics, and you're not going out and you're meeting those people as often as you should. I can tell you the biggest impact for me in a Medicaid director role in Kansas was when I went out and had those stakeholder engagement meetings and actually met those individuals who were getting those services and had them tell me their stories and tell me their stories about how they potentially weren't getting those services, or this is what's happening. Or you have a parent who's sitting there with their individual who's on the IDD waiver, and they're emotional, and they're telling me this. That has an impact. We've got to do that, and that's what I want to do. So from my perspective, when you take a look at an individual as you described, you know, we have to look at not just services, independence, and there are certain individuals in long-term care, absolutely, that probably will never leave a nursing home as well. I understand that. But you have to take a look at quality of care, quality of life.
Last question regarding CIS scores. Your exact quote actually was, I took copious notes for us this time. CIS scores were probably not taken as seriously as they should have. This is another issue that we're hearing from caretakers and from patients and patients' families that said when the CIS scores were initially rolled out to their families, some of them took them incredibly seriously. So roughly a 3.5 or 4 hour process, very extensive. On the same hand, we also had care coordinators out there that were probably newer, less experienced, and they said this is no big deal. Well, when you tell a family this is no big deal, fill it out to your best ability, and then it doesn't really mean anything at that point in time, now it's critical to the care that they have. The question that I have is, beyond the appeal process, what if they didn't fill it out correctly or it was inadequate? What do we, besides an appeal process, do they have a do-over? Can they fill it out again?
Well, I think as the deputy director suggested, if the care coordinator believes, family member believes that that assessment was not correctly filled out or not appropriately completed, then they can go to that case manager or care coordinator and ask that that be reevaluated.
I'm grateful that you pointed that out because Deputy Director Steer, to your point, what you said earlier when it came to the CIS scores was that if there has been a change in that patient, that they can fill it out. You've got a lot of parents and caretakers out there that are just being honest and transparent with all of us and saying, I filled it out to the best of my ability, but I didn't think it meant anything at the time. So what they're doing is they're calling in and they're saying, the question that's being asked is, was there a change? There was no change. I just don't feel like we filled it out to the best of our ability, and we'd like to do it again. And they're being told no.
I think we'll certainly have that discussion with managed care organizations and those who are performing that assessment, but I think to Deputy Director's point earlier as well, that's why we're actually going through, and I'm not aware of what that specific appeal process is, but they're working on that, and she said she has a meeting this afternoon to discuss so we can have that process in place.
If I can just add this, we're trying to be more flexible right now because we've been told people were a little more generous in terms of their abilities than they should have been. They didn't really evaluate it as harshly. And that's frustrating to me because it was not sold originally. The CIS-score wasn't designed for payment, it was designed for treatment, for care. And so to say, well, we kind of padded it and said he wasn't as serious as he was, when you know that's going to affect the care, is very frustrating for us. But now that we know, that should drive it more than payment, to be honest with you. The quality of care, and apparently payment's driving it more than the quality of care, so it's very frustrating to me. In spite of that frustration, we're trying to say we will try to work with people and get it corrected. Going forward, once it gets on the right basis, we can't keep doing that, let people play games with the CISC assessment. We're really going to hold them to it. If it changes, we're going to change it. Because people are on notice now. But I just want to tell you, it's frustrating to me that when they knew it was designed was to create the kind of care that we were going to provide, they weren't as concerned as they were when it came to payment. That's very frustrating to me.
I share in your frustration, but I thank you for the flexibility that you say you're going to provide to help these families get the care that they deserve.
Because, again, we're driving it back to care. We want the patient care.
Thank you, Mr. Chair.
Thank you. We're a little bit over time, but I'm going to let Mark ask a real quick question. Senator Shelton.
Thank you, Mr. Chair. I have a couple quick questions, but I'll go as quickly as I can on this process, because you made a statement that really triggered for me, which is you were talking about CAN care. You were talking about the change from being paid for fee-for-service to what you called normal pay cycle. You even alluded to a net 30 in that normal pay cycle. This is one of the major concerns I have in this process, which is, can you describe what the department's expectations are for providers to be paid and what the ramifications are if we're not? Because I understand that there's a metric in there that says that a certain amount of payments are acceptable to miss. But there's a huge difference between missing a $50 payment and missing a $1 million payment. And I want to make sure they're not treated in the same way. It should be a total dollar amount that's outstanding, not a quantity of payments they haven't been making. Can you elaborate as far as how that payment cycle is expected by the department?
As far as I know, the department does not dictate the payment cycle. The individual providers contract with the managed care organizations, and the state does not get in the middle of that particular contracting unless there's a serious issue that probably needs to be addressed. So that's an issue between the MCO and the providers, because they all have various contract rates that they are paid and terms of that contract, termination clause, et cetera, et cetera. So that's between the MCOs and those providers. From a state's perspective, and I don't know all the specifics, I'm still trying to determine that, but I do know in Kansas, in any managed care organization, managed care program, you're going to have specific metrics relative to claims payment. So normally you're going to have 99% or more clean claims paid in a certain period of time, 100% of those claims paid within a certain period of time. So that it's the state's expectation that those claims be paid appropriately per contract. And if there are significant challenges relative to payment, whether it's from the provider perspective or the MCO perspective, then those are things that we need to address as a state and understand what that issue might be, whether it's an educational issue for the MCO or the provider, if there's a system challenge, whatever that case might be. But it's no way is it acceptable for individual providers not to be paid in 6 months, 9 months, 12 months, if you were hearing those things. Those claims have got to be adjudicated, and those providers have got to be paid correctly.
If I can add to that too, I've been here just right at 6 months now, and I think most of you that know me know that I focus very heavily on the delay in payment for the MCOs when I came here and said this was unacceptable. And we have, I think, pushed the MCOs, and it's much better in terms of current claims. We still have old claims that haven't been paid that we need to push them on. But when we see, I meet with providers a lot, I try to be as open to providers as we can. When we see some delay in payments, we try to drill down and push the MCOs, what's going on, what's the problem here, let's fix it, let's get it paid. So I think most of your providers will probably tell you current claims are getting paid quicker now. It's still some of those old claims that are still sitting on it. That's the next, we need to fix that.
All right, well, I appreciate that. And based on the comment, I will say that, in my opinion, it's still a serious issue. So the sooner we can get that taken care of, the better off we are. Because in my opinion, we have very good providers in the state of Iowa, but they cannot continue to function as small businesses providing necessary services if they don't know when they're going to be paid. So that's a huge issue as far as I'm concerned. And then I'll have one quick question, because I know the chairs want to move on here. The department has a process where they're going taking 10,000 individuals going to fee-for-service. Does the department feel it has the FTEs and the ability to do this?
Working with CMS is a very short-term strategy. So the case managers for this 10,000 are DCF targeted case management. We're working with our professional contractors for the next, so that in early spring we can transition these members back to the managed care organizations.
I have some requests then real quick. One thing is, can you provide to the committee FTEs for the department prior to the managed care process, maybe even go a few years beyond that, so we can see, did we actually save anything as far as costs and FTEs in the department when we transitioned? How many the enrollees in Medicaid there were in the state of Iowa prior to and during the transition, because obviously if we're taking a much heavier load, then we have to calculate those two things into the process. And then also my question is going to be on this, which is, if the department's able to take these 10,000 individuals because of the transition, what is the capability of the department to keep these 10,000 and maybe add a few extras that may fall through the cracks? I want to know if the department has the ability to continue a pay-per-fee service running in parallel with the MCOs for the most critical or those individuals who've shown good stewardship of their own health, and if that's a possibility.
It's not under a current arrangement, but we'd be happy to provide you with what it would take to do that. But we do not have the infrastructure to do that at this point.
Thank you, and thank you, Mr. Chair.
Okay. Thank you. I think that's all the questions we have time for now. We're over a little bit, so appreciate you coming and speaking to it.
Thank you.
Okay, now we'd like to ask the managed care ombudsman program council.
Good morning.
Good morning.
Good morning. My name is Cynthia Peterson. I'm the State Long-Term Care Ombudsman. I would beg your indulgence on my heavy reliance on my notes this morning. I'm not quite as new as the new Medicaid director, but I'm still laboring under a learning curve. I've been asked to speak with you today regarding the recent reports that have been provided from the State Long-Term Care Ombudsman's Office regarding the managed care program, as well as issues that we have noted with managed care. The State Long-Term Care Ombudsman's Office, through two managed care ombudsmen, advocate for the rights and concerns of managed care members who are covered by one of the 7 HCBS waivers and managed care members who are receiving facility services. The Managed Care Ombudsman assists managed care members to understand their rights regarding service, care, and access to managed care, in addition to providing managed care members advice and assistance with filing complaints, grievances, and appeals. The first report that I'd like to discuss with you today is our executive summary. House File 2460 directs the State Long-Term Care Ombudsman's Office to annually submit to DHS an executive summary for inclusion in the DHS Medicaid Managed Care Annual Report. On November 14th, 2017, the State Long-Term Care Ombudsman's Office submitted to DHS the executive summary that has been provided to you. The executive summary contains a summary of information of the 4,187 contacts received by the Managed Care Ombudsman's Office during this time period, from October 1st, 2016 to the end of September 2017, including total contacts received by month, as well as the top 3 issues reported to the Managed Care Ombudsman during those contacts. The most recent executive summary also reported 2 issues to watch. 1 issue concerned payments to consumer-directed attendant care providers, and while provider payment is not a specific member issue addressed by the Managed Care Ombudsman, Managed Care Ombudsman heard this concern raised frequently because Managed Care members were concerned about losing a trusted CDAC provider as a result of payment issues. The second issue that we noted was a trend in an increase in the number of contacts to the office regarding state fair hearings. In October, November, and December of 2016, the Managed Care Ombudsman Program received 18 contacts regarding state fair hearings. For the months of July, August, and September 2017, the number of contacts regarding state fair hearings received by the Managed Care Ombudsman Program had increased to 169 contacts. The second report that I would like to talk with you about is the quarterly report. In addition to the executive summary provided to DHS each November, the Managed Care Ombudsman Program produces a quarterly report that is distributed in January, April, July, and October. The quarterly report provides a high-level overview of aggregate data for the prior 3 months, as well as a couple of examples of issues that had been resolved by the Managed Care Ombudsman. The quarterly report provided to you covers the months of July, August, and September of 2017 and includes the number of contacts for the quarter, the top 3 issues the Managed Care Ombudsman Program was contacted about, which Managed Care Program the most Managed Care Ombudsman Program contacts related to, as well as which MCO the contact concerned. Trends discussed by managed care members who contact the Managed Care Ombudsman Program are discussed in the quarterly report, as well as the Managed Care Ombudsman Program outreach efforts. In addition to the executive summary and the quarterly report, the Managed Care Ombudsman Program also provides to DHS monthly reports that provide detailed information by categories regarding contacts received by the Managed Care Ombudsman for that month. The monthly report contains information on the number of contacts received by the categories of access to billing and benefits, access to services and benefits, billing, care planning, customer service, eligibility, enrollment, guardianship, and other. These categories are further broken down into subcategories, best describing the reason for the contact received by the Managed Care Ombudsman. Contacts are also tracked in the individual categories of grievances, appeals, and fair hearings. The monthly report also contains detail regarding which MCO the contact is regarding, beginning with the monthly report for December 2017. This report section will also include the number of fee-for-service contacts the Managed Care Ombudsman received. In addition, the monthly report also contains data regarding the program category which is discussed during the contact with the Managed Care Ombudsman. When a Managed Care Ombudsman makes a referral to another organization, it is noted in the monthly report, and information regarding the type of service the Managed Care Ombudsman provided to the contact is also contained in the monthly report. All 3 of the reports discussed are available on the Managed Care Ombudsman Program website. Going forward, we will be tweaking the way that we handle these reports, the information that is provided in the reports, and as opposed to contacts, and not just because I can't say the word, as opposed to contacts, we will have the type of outreach that we received from a member? Is it something that is an activity? Is it something that rises to the level of a case? That's how we're more familiar in the ombudsman world of tracking the services that we provide, and we will be transitioning to that same system going forward with the Managed Care Ombudsman Program. There are a few things that I would like to highlight from my review of the monthly reports from October 2016 through September 2017. As I mentioned earlier, during this time period, Managed Care Ombudsman received a total of 4,187 contacts. 1,819 of those contacts were related to services being reduced, denied, or terminated. 455 of those contacts involved care planning participation. 933 of the contacts were regarding the elderly waiver. 883 of the contacts concerned the intellectual disability waiver. The number of contacts received by the Managed Care Ombudsman relating to an inquiry regarding a specific managed care organization is as follows. 2,332 contacts were made to the Managed Care Ombudsman Program regarding AmeriHealth Caritas. 864 contacts were made to the Managed Care Ombudsman Program regarding United Health. 737 contacts were made to the Managed Care Ombudsman Program regarding AmeriGroup. Finally, the Managed Care Ombudsman Program is currently tracking contacts about the transition away from managed care services formerly provided by AmeriHealth Caritas. I have provided a table that shows two of the categories from the monthly report. The first category is transition services and coverage inadequate or inaccessible, and the second category is selecting or changing an MCO. The Managed Care Ombudsman have reported to me that in general they have not seen an overall increase in the number of contacts at this time. However, the subject matter of the contacts has changed, and they have noted an increase in contacts in the categories of transition services and coverage inadequate or inaccessible from 43 contacts last November to 59 this November. There were a total of 304 contacts regarding this category from October 2016 to the end of September 2017. My table has a typographical error and the total says 34, but it is actually 304. In addition, there has been an increase in contacts to the Managed Care Ombudsman Program regarding selecting or changing MCOs from 5 during the time period of October 2016 to the end of September 2017 to 58 during the last 2 months. These are trends that the Managed Care Ombudsman Program will be monitoring.
Okay, thank you. Are there any questions from the committee? Representative Fry.
Thank you for joining us and welcome to the table. I know you've had a steep learning curve as well in the process. This is not so much a question, more of a request, that would be really helpful to see the trending in a graph form somehow. You rattled off a lot of specific statistics that I couldn't keep up with. And if we could see some graphing or trending over time and some baselines, that would be excellent in some of the statistics you were talking about. So when I go to the last page of your report, and you were talking about these two particular categories, did you just pull these out as an example of what you're monitoring, or are these, I wasn't clear, are these two very specific trendings that you're watching at the current moment?
These are two areas that we have tracked traditionally.
Okay.
These are just two areas that the girls brought to my attention because they saw such an increase and a shift.
Okay.
Normally, our top complaints would be something along the line of denial of services or something like that, but these rose to number 1 and they just wanted to let me know.
Okay, thank you. When I look at page 3 and 4 of your of your chart there on after the executive summary, page 3 and 4, after the executive summary, and I noticed that care planning participation, you also highlighted that in your comments. Care planning participation, can you give me an idea of what the calls are related to that? Because that is a significant issue from a healthcare provider standpoint, in my opinion. If the member or family or designee is not being allowed to participate in the care planning process of their own care.
It's my understanding that what our managed care ombudsmen are seeing are issues that relate to inadequate exchange of information, as well as participation in the care planning, and also failure to follow the care plan once it's in place.
Okay, thank you. I would ask that would be something, because that shows up kind of in the midsection of the summer. I would ask that you would watch that very closely, because I think that is a trigger for identification of appropriate care being provided or not. And my final question that I have for you is, when you go to page 4 then, the access to durable medical equipment shows up for August and September all of a sudden. That also is a trigger in my mind as a healthcare provider that if someone doesn't have the access to the right equipment needed for their level of care, they're not going to receive, especially at home, they're not going to receive the care that they need specific to their condition. Can you give any insight into why that's showing up, or what specifics would center around that?
Unfortunately, that is one of the issues with our data gathering system right now. It could be something as simple as the top 2 categories, the numbers were lower, so that finally made it into the top 3. So I hope to be able to provide better specifics.
Thank you. Thank you, Mr. Chair.
Senator Matthews?
Well, thanks for coming today. There's a lot of data here. And I think the first question that I have is on page 3, where you have contacts per MCO, and AmeriHealth certainly has, you have a lot more contacts from them. Do you feel that based on perhaps a data analysis, they had more complicated cases?
I don't have that information.
On page 4, you talk about members have the right to legal representation, and then the last line is, at best, a member has a provider or advocate assisting them. How do you work with legal aid in this regard? Do you refer clients there, or people who are complainants who are looking for someone to help them?
We refer managed care members to both Iowa Legal Aid and Disability Rights Iowa for legal assistance.
Okay. And Disability Rights Iowa is currently in a lawsuit. I think they're bringing a lawsuit forward, or have already. And my last question is, certainly you probably read a lot of other information in regard to professionalism around your position and your job, and learning more about what it is that an ombudsman does in other states. How does this compare to an emerging transition to managed care in other states? How would you evaluate the amount of complaints we're seeing compared to implementation in other states where there's managed care?
Unfortunately, I do not have the ability to comment on that at this time. Given the limitations of our data gathering, I'm not even sure if the amount of contacts that I report out on are duplicated or not. So as I tweak the data gathering information system going forward, I hope to have a better idea. The other thing that I would like to have people keep in mind is the managed care population is very large, 568 some odd thousand people. We had less than 5,000 contacts, if those are in fact unduplicated contacts. So the reports that I can offer are numbers for actual people that reach out to us and contact us, but I'm not sure I'm in a position to be able to comment on any trends or anything like that, just given the small amount of contacts that we've received so far.
How do they find you? You're saying there are 5,000 people that contacted you. How do they find you? Did you do a marketing effort? Do you work with pharmacies? What do you do?
When the managed care ombudsman program first came into existence, we did a mailing to all of the managed care members that would be in the population that we serve. We also do outreach work whereby we continue to provide information, continue to provide mailings. We have a website. Anyone who contacts one of our ombudsmen that's out in the regions that has this type of an issue would be referred directly into the office. There is a marketing effort that we will be undergoing as part of the State Long-Term Care Ombudsman's Office beginning next year, and we will also be providing information on how to reach out to our managed care ombudsman program.
All right, thank you.
Okay, Representative Evans.
Oh, great, I'm here. Thank you.
Didn't have a list until you just said, okay.
Oh, okay, great. Well, thank you. Want to lift? That's okay. Okay, all right. Thank you for being here today. So my first question would be, can you, I guess I'd like to know where your staffing levels are at right now.
We have 2 managed care ombudsmen in the managed care ombudsman program.
2 managed care ombudsmen in the managed care ombudsman program, okay. And then when you're looking at, since you just referenced, you want to relook at your number of contracts and are you including any of those? I'm hoping when you do that, you're looking at, I could call you twice, but it might be for 2 different issues. So that I may be a duplicate person on there, but I've called on 2 different
That's correct.
things. So that makes sure you're doing that particular information. I do have a question on the, your trends that you're seeing. And I noticed actually for all the months, I mean every single month that I looked on here, that when I look at the last pages, well, except for maybe November of 2016, but all the other months from December 2016 to July now, it has reduced, denied, or terminated services. Every single month. And so my question directly to consumer-directed attendant care, are you seeing then, from what I'm gathering from here, is an upswing of folks who are being reduced or denied or potentially terminated in CDAC delivery of services? I just want to make sure that I am clear on your statement here.
I don't know that I can say that there is an increase. I know that it's one of the more prevalent concerns that was brought to our office during this time frame.
Thank you. I mean, I know of several people in my area who had CDAC services that have been dramatically cut in half. When you're looking at a 28-year-old potentially going into a nursing home because of the care they need, I'm thinking that's not really going to be a cost savings to the state at all. And I also find it pretty appalling that every month reduced, denied, or terminated services. Thank you.
Senator Reagan.
Thank you, Mr. Chair. So the long-term care ombudsman is a separate report.
The long-term care ombudsman uses a separate reporting system, and the report that we provide is the annual report that we put out. It had been coming out in January. I think it will be a little later this year. There does include some information from the managed care program in that report, but we are currently using 2 different tracking systems.
So their numbers are not in here.
The state long-term care ombudsman, the regional gals numbers are not in here.
So there are more.
There may be more, yes.
I'm guessing there are. Just guess. So when you get this information, I think there's a lot here, and I think there's concern. What do you do with it? I mean, you refer them on. Do you contact anybody? Do you say, wow, I'm seeing a trend here. I'm seeing people getting reduction in services. I'm seeing, concerns with any of this access, any of that. Do you talk to any other department? Do you communicate?
We provide these reports to DHS, so they have this information as well. And as advocates, we can only take the actions that the member that we're working with will allow us to take. So if they should ask that we contact one of you, for example, we would certainly do that. And once I'm a little more sure of the data and what we are seeing and the things that we're able to resolve, because that may, in fact, impact the denial of services, in that we may be able to make some phone calls or talk with some folks and get those services restored. I just don't have that information being tracked at this time.
So that would relieve them coming back to you if you solve the problem. I think that it seems like there should be a solution at the end of some of this.
Agreed.
And
Unfortunately,
so,
right now, we don't have outcomes.
so have you had a reduction in staff?
No, these are things that we're noticing with the data tracking system that was put in place at the beginning of the program. And as you know, when something's new, sometimes you have to tweak it as you go.
So since you've been there, you've had no reduction in staff?
There was a reduction in staff of the program manager for this particular program.
Okay. But other than that, you haven't seen that?
Not for the managed care office.
Okay, so I'm hoping that we can get something established so maybe we can get better outcomes. Thank you.
Okay, Senator Segamark.
Cynthia, thank you for being here this morning. Just easy, short questions. There are 3 ombudsmen then? No, I can't say ombudsman, so that's, I'm with you there. Are there 3, 2 plus you, or just 2?
There are 2 that are dedicated to the managed care ombudsman program, and then I serve as their lead one.
So my real question here is, how is their morale? Would you have turnover in those 2 during the year? Are you trying to find somebody every month, or just a general
No,
question?
those are the same 2 long-term care, managed care ombudsmen that we brought into the program.
Okay, so do they feel good about their jobs? I mean, they've got an unending source of business. But if they're not having success, they can get burned out very quickly. And so that's why I'm asking if you've had turnover in that job.
There are successes. Unfortunately, I don't have accurate tracking of those successes.
But your general feeling with those 2, are they happy to go to work every day, or are they dragging their feet?
My general feeling on those 2 is that they are doing an absolutely wonderful job, and the stresses that they feel would be the same as anyone else in our department right now, just given the insecurity with the budget situations.
Thank you, Cynthia.
Okay, thank you, Cynthia. We appreciate your report. And it is time for our lunch break. We will plan on being back here at 1 p.m. for a committee discussion with the managed care organizations. Thank you.
It was, timing was almost perfect.
She was here, man. She just stepped out there. And it looks like you got her. Oh, that's what I got. Oh, I don't think so. She'll be back. We'll give them a couple minutes. They're not that many girls. We're only missing 1. Oh, no, it doesn't matter. Let's go. I think he's got trouble.
Okay, I guess we're ready to start again. So at this time, I'd like to ask the representatives from the managed care organizations to come up. Kim and Cynthia. Thank you for coming, and I'm sure you were listening in as we were working out this morning. If you want to address maybe some of those questions that you've heard come up, and whatever you'd like to share with us, and then we'll have time for question after you've given some open statements.
Good afternoon. Kim Foltz of United Healthcare. Excited to be here today. I really want to start by just really talking about what we have done. So United Healthcare stepped up when asked by the state to take on these additional members impacted by what was occurring in the state. We transitioned 208,000 members in 19 business days. We hired over 400 individuals in 19 business days. We outreached to over 25,000 individuals prior to 12/1 as that outreach started to help them through transition. Over 5,000 of those long-term supports and services members that we began to engage even before we took over management of those members on 12/1. We have exchanged thousands of files of information in 19 business days. And so as we sit here today, we're very proud of the work that has been done, how we have really truly worked through this transition in a very focused and disciplined way in collaboration with our state partner to ensure that members are transitioned effectively and that we are doing all that we can to ensure that transition occurred as seamlessly as possible. And so I know we'll talk today about some of the questions you have, and again, I would say that we are very proud of the work that we've done, and it has been no less than a very monumental shift that's occurred in a very short period of time. And there are very few issues that we've identified today. We clearly stated that we would have some bumps, but when we look in terms of what those are, they have been very minimal to date. And so we'll talk about, again, those questions that you have, but we are, again, very proud of the work that's transpired so far and the work that we're continuing to do with those 208 individuals that transitioned over to us just 18 days ago.
I'll just introduce myself, Cynthia McDonald with the Mayor Group. I'm plan president. Very happy to be here as always. I think it's really important for us to dialogue and certainly I'm open to answer, as always, any questions. I'll assume that you have some questions for me about capacity and our not really a decision, but reality of what we could take on and how soon could we do that. So we can either have you ask questions of me, or I can address that a bit too if you want.
Okay. I guess we'll just start asking questions. Kim, I would like for you to explain to us what is happening with the IHHs. And one of my concerns that maybe have been voiced is that the providers and the members get enough time to make that transition smoothly. And if that's happening, or maybe some of your communication plans and what has gone wrong. Apparently, a lot of people are sending us emails, so that's not a good indication. So if you'd address that, I want to give you the opportunity to explain what's happening from your point of view.
Sure, we can jump right into that. So I think I'd just like to step back and talk about the health home programs and the intent of the health home program. So the activities that the health homes conduct today are defined as administrative activities, administrative care coordination activities. So I want to be very clear that as we talk about the impacts, that there are no impacts to the clinical service delivery for members. So things, critical services, the clinical services, the therapy services, the B3 services, which include peer support, BHIS services, these services are all individually reimbursed, billed separately. We're not talking about clinical service delivery that's been impacted here. What we're talking about is the administrative care coordination activities that are present. United Healthcare has a very intensive approach to case management. It's very important that members get the services that they need. And that is really important. We track our members' utilization. We work with providers to ensure that they are getting the care coordination that they need. United Healthcare was the first MCO to execute and have active accountable care organizations arrangements in place. That's our commitment to care coordination and ensuring that individuals have those services, that we are focused on those that have the most chronic needs, the most acute needs, and that they are getting that care coordination that they need. When we look at our obligation as an MCO, it is really truly to manage those administrative dollars and those administrative expenses as effectively and efficiently as we possibly can, and to ensure that they're actually being delivered and that there's outcomes associated with that. So over our first 20 months of experience in the program, we've continued to have a very extensive data analysis on an ongoing basis to ensure, again, where are our members' needs, how are we working with providers to meet those needs. United Healthcare has not made any changes in the way we approach the work that we have with integrated health homes. What we do know now, and certainly in retrospect, we identified and understand now that the differences in how we were working in the program and how AmeriHealth worked in the program were different. And that's truly, a lot of that starts with those accountable care organization agreements that we have in place. So there's aspects of those agreements that have those administrative care coordination activities included in them as a part of those expectations. And so our goal is to ensure that there isn't a duplication of those services occurring. And so when we approached this process, I will say we received the final file of health home members from AmeriHealth on December 1st. And in our work to execute as quickly as possible and get notifications out through our standard notification process, we process those files against what our process is today, which is to ensure that duplication doesn't exist. When that standard notification went out, we were alerted to the impact of what that was, and quite quickly by providers. And so that was on the 7th of December. We assembled discussions with the state, we assembled discussions with the associations to better understand where those differences were. And as you have heard, we agreed to take a short pause on last Friday as we took about a week to really evaluate and understand that and make sure that we truly were understanding what the questions were. And we're pausing for the month of December, but I want to be very clear, we have not made changes in how we address the case management care coordination activities and needs of our members. And so we have both those accountable care organizations, but also internal resources that focus very heavily. We have those resources that have worked with our integrated health homes and chronic condition health homes over the first 20 months, and we have additional care coordination resources that are focused because, again, as we are data mining and understanding those needs, we're finding that in many cases those members aren't getting their needs met, and they are continuing. We aren't seeing those outcomes. We're not seeing reduced ER visits. We're not seeing reduced inpatient admissions. So we're activating our resources to ensure that those services are getting wrapped around those members. Because at the end of the day, we aren't benefited by not giving members the services they need. We are in a full risk contract with the state, and so we don't want to see ER visits. We don't want to see increased inpatient visits. It is really important that that doesn't happen, so we are ensuring that those services are available and that we're wrapping those services around the members. And so I would say today, we understand that there is differences in how that program was administered, and we're addressing that, and we want to step back and make sure that there's an understanding of that. And if there are additional communications that need to take place, again, retrospect, understanding now the questions. Could we have done something outside our standard notification process? Sure, we could have. We were moving very quickly through this transition. And I would say, again, this is one area. We admitted that there could be bumps in the process. I'd really characterize this as one of those bumps that we respond to do very quickly to help identify and understand how we move forward in a way that ensures members' services are being rendered and that those services are available. And again, want to be very clear, no clinical services in the clinical service delivery model. Peer support, billed separately. Those therapy services, billed separately. They're not included in these administrative activities that we're talking about that are really the emphasis and the basis of the discussion.
Okay, thank you. Thank you. Maybe a little bit of a follow-up to that. So United does utilize integrated health homes in your program, some, and you're not going to remove all of them, even on your plan. Okay, so I'd heard that, I understand there's maybe a duplication of services as well, and maybe you think you can do it better another way, which, that might be good. But you are not planning to totally eliminate use of the integrated health homes, because I'm thinking about if all the United members go away, then they have a few AmeriGroup on staff, are they going to be able to function as a business? And have you thought about that impact? I mean, I'm a little concerned about that as well.
So I think that there's several things that we want to try and discuss. So today, we enroll individuals that are in the CMH and also habilitation waiver services. Those particular services and waiver programs in general are currently carved out of accountable care organizations, and that's as defined in our relationship with the state, but at this point in time, that those individuals are not part of the accountable care organization requirements. So we continue to enroll those individuals because those are not, the accountable care organization is not the vehicle of which they can get those services as they're carved out today. When we think in terms of what we're doing is we're working with those accountable care organizations. They're not all created equal. They're not all ready to handle and manage all of the behavioral health needs of our members. Many of them are, though. They're working with the community mental health centers. Part of this is driving truly an integrated approach to that service delivery model and making sure that the individual and their services are met holistically. So as we sit here today, our intent, and as we have communicated very clearly and transparently, we've answered many questions, even over the last month, as how we are administering the program. We've been very open and very clear about how we're administering the program, who we are enrolling and who we are not enrolling, and why we're not enrolling them is because of program implications. And so that's where we sit today. We will always, as any managed care organization and any Medicaid program across the country continues to evolve, we'll look at ways of which we can be more effective and efficient and drive better outcomes and quality into the system. So that will be and continue to be our focus, is driving outcomes, quality service delivery, and ensuring that members are getting what they need based on their needs.
Okay, thank you. One more question from me. It's nice being the chair for a shot. Okay, so we use the terminology that we were in a fee-for-service program and now we're moving to managed care or a value-based system. And as I understand it, that's one of we can truly move to a value-based system. That's where some of our savings are going to occur and better outcomes. And it seems to me a lot of times you guys are still just paying fee for service. And how do we get to that point? And is that going to be another difficult transition?
So I'm so glad you asked that, because really that is the basis of where we're sitting at today. We are driving to that value-based arrangement and moving that care to a value-based system and structure. So integrated health homes today are a fee-for-service structure. There is no value-based, there's no shared savings. It's a fee-for-service. It's a fee-for-service rate, it's a fee-for-service PM. When we think in terms of this delivery model, we are moving things to the accountable care organizations where there is a shared savings opportunity. We're working together collaboratively to drive those outcomes and drive savings into the program. We're mutually benefited by those savings that we're driving in the program. So aligning and ensuring members get the services they need becomes then a mutual goal and objective through those value-based arrangements. So when I say accountable care organizations, those are value-based agreements, shared savings agreements that drive that value into the program. And so that's the distinctive difference. We are absolutely, effectively moving down that pathway today.
Okay. Have you got a comment on that, Cynthia?
I would certainly echo that. I think we're all very anxious as we continue to drive down the path to value-based purchasing, and that's clearly is where we are as well, and driving that forward. As to the health home piece, we certainly support the concept of health home and figuring out then how do they fit within this construct of the drive forward of value-based and the sustainability overall in terms of their sustainability potentially, and then the sustainability within the program as we drive to this kind of next generation, if you will, of the program here in Iowa.
Okay, thank you. That's the questions I have. We'll check our list here and see where we're going. Okay, Representative Fry.
Thank you, Mr. Chair. Excuse me. Thank you, ladies, for being present today and having the discussion with us. We appreciate your work in the state of Iowa. And thank you, United, for stepping up and helping the state in a situation that needed to be taken care of rather quickly. First question I have, similar to what I asked the department this morning, deals with your understanding of the geographic outlays of our ACOs. And from your perspectives, looking at a state map, if you will, give us your condition of the ACO across the state of Iowa, please.
So when we look at today the ACOs, we have 7 ACO agreements that are active and in place. And so we've done just that. We have mapped them and looked at them based on the geographic locations around the state. And when you think about some of those accountable care organizations, they are the large health systems, and they cover a broad geographic swath of the state. And so we look today and say, when we have those accountable care organizations, that's the hierarchy of value-based contracting. We want to work with those accountable care organizations to drive that value and those shared savings into the system. So that's where our commitment is to drive and work with those accountable care organizations. So we do have that map, and so today, we have individuals enrolled in both chronic condition health homes and integrated health homes. And today, those have been by chronic condition health homes. If there's not ACO coverage, we have staged that over the period of time. So those have come on over the last 20 months. So we've staged that. And by the way, for chronic condition health homes, it's a 100% overlap in the activities that are conducted by the chronic condition health home versus the ACO. These are medical-based, definitely medical-based services. And so we've mapped that out. In all cases, it's the same primary care provider. So that doesn't change at all. So where there is that one-to-one ratio, we've transitioned those individuals. The shared savings arrangement is more favorable for the system, but it's also more favorable for the provider in the end, because again, they have that opportunity to share in the collective work. They're doing great work. They really are organizing their structures and their provider service delivery model around that care coordination activity and that work that's happening. So we want to drive that incentive for them as well. And again, it's focused on driving value into the system. So we also, again, as I said, have individuals enrolled in integrated health homes. Today, the waiver programs are carved out of accountable care organizations. So those individuals are in health homes, and because they have those needs, and or they're in our internal case management program. So if they have a targeted case manager, a community-based case manager, those individuals are doing the same exact service. They are helping facilitate if there's employment needs, if there's nutrition, food-based insecurity needs, if there's housing assistance that's needed. Those are all types of services that our community-based case managers are providing one-to-one coordination with the member and their family and the providers.
I probably don't have that much more to add. I think Ken's response was comprehensive. I would say we're probably a little bit more in the development stage of that, being brand new to the market when we arrived here in end of 2015 and without a commercial base. So I think that's a continued drive for us as we talk, especially with the big systems, but also the FQHCs, the Federal Qualified Health Centers, and we're not there yet, but interested in also figuring out how we can engage community providers as well into the system as a whole as we lift to value-based. So.
Okay. Good, thank you. Cynthia, this is probably more for you and conversation around the ramp up of what will happen in the next 3, 4, 5 months of Merit Group being able to take on new clientele. Can you give us your perspective of where you think that's headed, how soon? I'm not asking for a date, but where you're at, the state of the state.
Sure. I would say, maybe I'll just step back and say, one of the evaluation pieces that we immediately went into as we heard the news about AmeriHealth, probably pretty much at the same time everyone else did. So in that initial, right off the bat, had concerns about just our capacity. Remembering we serve 200,000 members today, and so our first concern would be serving our members, and we are ramped and staffed for that service to those members, and certainly don't want to deviate from that and our commitment around that. But as we looked at our plan around this, one of the things that we do as a company, which is not to say other companies don't do this, but we spent a lot of time thinking about being steady and responsible and sustainable in any state we're in, clearly in Iowa as well, and really thinking and being candid about what we thought we could take on and what we couldn't. I admire United for moving very quickly and taking on that level of enrollment. It's something that we wanted to take some time and think it through. So I don't have a date per se to share. I think thinking about as we move through the next couple of months and probably around the spring view of where we'll be on capacity. And we have not said no to capacity. We've said we need to really do it right, and we need the time to develop that. Just even ramping and hiring staff, recruiting staff, which sometimes can be a little challenging in the rural parts of Iowa to find a level of case managers. And we have great case managers now, but we employ a lot of people in the field now. So to ramp to new staffing, to hire them, get them hired, and train them, that it takes a little bit of time. And so, but we are moving to that, and we're working and coordinating, I think, very well with the department on that. I think they've been very responsible to us, and we've been hopefully responsible to them as we work this through, and also knowing that our partner is CMS also as well, to make sure that we are meeting the needs but also ensuring we've got a viable process for our company as we move forward.
So I hear you saying you are ramping up and you are moving in that direction.
We're in that planning process, yes.
Planning process means what?
Planning process means we, for instance, we've had 2 job fairs, and we are, moving as tangibly as we can as we look at what it means. So part of this too is what is the membership that will come to us, and the membership and when will it come to us, in what getting the files ready, and all. I think the things that Kim mentioned, there's a lot of administrative work that comes at you, and you have to be ready to take that on, and ensuring that we not only take care of the members, of course, first and foremost, but ensuring that we are working very closely with providers. And part of this is also ensuring we've got contracts in place. We've got a pretty strong breadth of contracts and providers all around the state, but ensuring that we've got the providers that are, frankly, if there's any gap, you do a gap analysis, make sure, and then you go out with a contracting strategy to ensure that you can bring on those providers as well. That continuity, of course, sort of the underscoring of how important that is to ensure that we are ready for that, and we've hit it on our day one.
One final question for me, and then I'll be quiet. This goes to the CIS conversation. Do both of your organizations keep that in-house and administer that, or is that done by a third party outside of the organization?
We today have a combination of having it done in-house, and we also utilize Telegen, which was the prior provider for the state. We evaluate today. Our goal is, and always, is to ensure that that assessment is an accurate reflection of the member's needs, and that it's done accurately, that it's quality, and it's quality reviewed. And so that's a really important step when we think in terms of that assessment delivery and making sure that it's completed correctly.
And we have a dedicated assessment team trained specifically to do this. They do it under the auspice of a national organization and under those standards. And so we work it through, again, under national standards, but then work it through within our team to ensure that all the performance standards that we have around that.
Thank you. Thanks to both of you. Thank you, Mr. Chair.
Okay, Representative Hedges.
Thank you, Mr. Chair. Thank you both for being here today. And I do have 3 questions. First one, Cynthia, is going to be for you. Can you give me an update as to where AmeriGroup and Unity Point are in their discussions? Because December 31st is, 13 days away.
It's coming up, isn't it? Yes. Yes. So I would say this. I remain very hopeful that we will be able to have a deal by the end of the year. 12/31 is that date. But we've had some very good conversations with them, actually very frequent conversations as the intensity of these next 2 weeks, which is not uncommon in contract negotiations, if you've ever done those, and that we, have members very much in mind as we drive to that date and drive to the kinds of conversations that we're having with Unity Point. Again, I think they're good conversations. They're not antagonistic. They're productive, and we're trying to drive to a base of it, which is value-based contracting, ultimately, to move that forward.
So do you have a contingency plan should they not? Because I would assume that's going to impact your network, the efficacy of your network.
Yeah, we do, and I think that's a fair question. We would continue to have network adequacy without Unity Point in our network. But having said that, I would rather not. I'd rather have them in our network. They're a value provider to us for lots of reasons, and most importantly for members. So should we go that route, we would be able to meet adequacy, but again, that would not be the preferred position.
Thank you. Okay, I'm going to go back to the integrated health home. Can you just reference that you're kind of on a pause or continuing as is through the month of December? So can you tell me what's going to happen in January? Because providers found out December 7th with the change and still concerned of whether they were going to get paid from services provided, December 1st. Again, January 1 is now 14 days away, 13 days away. What's the plan? I mean, when are you going to be telling providers? Are you going to be telling consumers of any changes? What?
Sure. So we've been in conversations with the state to truly make sure that we're in alignment with those expectations. And again, I would say, to date, our standard process is whether or not we enroll an individual that comes across, we get that out in that first week of the month. So when you talk about December 7th, whether it was November 7th or October 7th, it's a general time frame. When those enrollment requests come through, we process the rosters and notify through the roster process. So that's the standard notification that's been in place since April of 2016. And so when we think about when we go forward, what we indicated is that we would take December on those individuals that there are program duplications that exist. We will pay those health home payments for those individuals. So updated rosters started to be generated even late Friday out to providers to let them know that December they would be on they're on an updated roster. Right now, what we've indicated that we would be willing to do is, again, go forward with that process and into January. And right now, we're targeting in our discussions with the state a January 31st date. And again, we have to be very careful because there are program duplications. So part of what is federal guidelines, state guidelines, is to ensure that duplication doesn't exist. And so we're in conversations with the state to make sure there's a strong understanding about how we're going to manage through those duplications. But right now, understanding that providers have, there are revenue impacts for the providers, we recognize that, and that we certainly want to work with them. We have individuals that continue to need to be served by those integrated health homes. And so the idea here is not to create any dismantling for those particular members that don't have program duplications that have the need for those care coordination activities. So we are working to ensure that there's additional communications so that we can be clearer than we thought we were initially, to ensure that there's transition and there's understanding.
So I guess I'm a little, what is January 31st? Is that when you're saying you're not providing that service anymore, or it was a little unclear on your statement?
Right now, we're targeting to allow program duplication to exist through the end of January.
Okay. So when are you then going to notify, back to my original question, when will you notify providers? Because, I mean, they found out this time into
notification, we have documentation, talking points, frequently asked questions, information that we are currently getting reviewed by the state. They have to approve any notifications. Anything outside of standard notification then has to go through an approval process. So those documents are at the state for review and approval. We're exchanging them. So we would expect to have those out before the end of the year.
Okay, okay. And then I guess my last kind of question goes to when you talk about duplication, I think one of the topics has been on case management. And if I'm correct, both of you have in-house case management for clients. Is that correct? So I'm still trying to figure out how that meets the conflict-free. Because if you're the agency that's providing the service, or as in the Ombudsman's report, every month except for the very first month it was reduced, denial, or termination of service, usually you're going to have a case manager that's going to be advocating on your behalf. And if I recall, in Kansas, the legislature actually stepped in and said, no, you can't be providing case management services. The consumers have to have a choice there. So how are you addressing conflict-free? Because I'm not really seeing that, but I'm open to hearing what you have to say.
So conflict-free is truly the differentiation between the entity or the individual that completes the assessment versus the individual that completes the service plan that's based on that assessment, and ensuring that those services based on the assessment are meeting the needs of the member based on the assessment.
Right, but your assessments are also in-house.
They're in-house, but they're distinct and separate teams. They are not the same individuals. They are completely separate. There is no crossover. There's not an individual that completes assessments on one day and does community-based case management the next day. They're very separate and distinct resources. And so that separation, ensuring that the assessment is completed accurately, and then the care coordination and the case management services are done separately. And you heard earlier from Deputy Director Steer, this is not something that arbitrarily gets done. Reductions in services do not arbitrarily get done. Any reduction from a level of care has to go to the state in order to be reviewed to ensure that it meets the specifications of the service plan. And what I will say is many of those questions, and by the way, they're very small numbers when you think about the population, the large population that we're serving. When you look at those particular questions, many of them, it's not actually a reduction in service. It's truly an alignment of the services, and it's also alignment with that Medicaid hierarchy of payment, making sure that the Medicaid state plan is paying for a service that can be delivered and is a benefit under the state plan before it goes to the waiver. So many of that is just an understanding of how those services are aligned. If you have a need for supportive activities of daily living, those don't arbitrarily go away. But what may have been in your service plan before may not be an accurate reflection of the services you actually were receiving. So to align that service plan and align it with the actual needs, that's the intent. And again, any reductions of services as a result of the level of care are all reviewed by the state to ensure that they are appropriate.
I appreciate that, but I will say that the hundreds of people that have contacted me, and I'm not referring to the providers, but the families that have contacted me, they've been a reduction. And whether you say, the state has approved it or not, it is a reduction, and it is a health impact to them. I've been a critic of managed care all along, and I'm going to continue to be, just mainly because of, it seems like arbitrary reductions that are going on. And as I said, we've got the managed care report here in front of us that shows every month one of the issues of the calls are being reduced, denied, or terminated of services.
There are no arbitrary reductions of services that are taking place. And so what I would say is that we listen very carefully and thoughtfully to any of those concerns that are expressed, and we work with the state. There is a very strong oversight process. I would say, and we applaud Iowa, the strongest in the country from an oversight perspective. And so there is that process in place to ensure that those checks and balances are appropriate. We are to manage care and make sure that members' needs are met and that care aligns with those needs. And that's what we do every day, and it is always our intent to ensure that members' needs are met.
thank you, Mr. Chair, for allowing me to ask those questions. I still would say that I think there's a lot of members whose needs are not being met.
Representative Forbes.
Thank you, Mr. Chairman. This morning I asked this question to the directors. My question was dealing with case managers and care coordinators. It's come to my attention from more than one person that possibly your organizations are paying bonuses to case workers, case managers, for bonusing them for what's considered or called increasing independence, which in turn, as Representative Hiddens has alluded to, is actually a reduction in services to patients. Can you tell me if your organizations pay bonuses to caseworkers or care coordinators?
Here's my very strong response. Absolutely none.
Okay.
Unequivocally, no. Absolutely not.
Okay. So if we were to subpoena payroll records from your organizations, that would back up what you're telling me today?
Yes.
If you need an affirmation, yes.
Okay. You know, I'm going off, I don't have any facts or proofs, but I've been told that that's happening within at least one or more organizations.
But may I just ask, is there anything further you can share on that, or where is that coming from? Because it's actually, I heard your question earlier. And
Yeah. Well, I can't divulge that right at this point in time.
Yes,
But it's very concerning to me if it is going on.
It's quite disturbing to actually hear that. So I think that we would welcome any information and more detail, because that's just simply not truthful. It's not happening, and any allegations to suggest otherwise, again, is very, very concerning.
Okay, I'm just going off of what I've been told by other people. I'm not accusing, I'm just asking the question. Second question would be to Cynthia. You know, rumors around here are a dime a dozen. And I've heard rumors that possibly AmeriGroup is possibly considering terminating its contract with the state of Iowa. Can you confirm or deny there's been any discussion or letters to that nature?
Sure. First of all, let me say that it's more common than I am comfortable with, where AmeriHealth and AmeriGroup get mixed up. Even recently on agendas, it gets mixed up. So just to be clear, we are AmeriGroup and AmeriHealth is gone, so maybe that will help clarify. Honestly, we heard that. In fact, I talked with the department about that over the course of really since AmeriHealth's announcement. And because we heard a lot of rumor, especially out in around the state, that we heard you're going to be gone. And you can imagine, so first of all, it's not true. You can imagine the consternation. I've got 400 people that we employ around the state, and my worry and concern almost went to them first, which is to try to dispel that. So having said that, sustainability of the program, this is not a new issue that we've talked about here in this forum, this sustainability and the sort of true costs of the Medicaid program in Iowa is a continual concern, but we are committed to working through the sustainability. I think we have good dialogue, strong dialogue, transparent, candid dialogue, intense dialogue sometimes with the state, but that's all part and parcel of helping sustain the program and build it to the future.
Well, thank you for your answer. I just, that's been going around. I just wanted to clear the air on that to see if this was true or not. So that's my questions.
Okay, Representative Taylor.
Jeez, I feel like I'm tag teaming you today, John. Thank you, Mr. Chair. Ms. Foltz, I wanted to just clear the air here a little bit. Something's been on my mind. I hear you continue to say this about every meeting that we have of these bumps that we've had. You said that earlier today. I've heard you say it a number of times here. What I want to tell you is that when you say bumps, what goes off in my mind and many people in this room's mind is those bumps are people. Those bumps are patients that are not receiving the services that they were promised, or the providers that provided the service and are not getting paid. We need to overcome those bumps. If we're going to move forward with this MCO model, we're going to have to overcome those. We're going to need both of your help. But the question that I have for you is this. Your statement earlier, it's very important that our members get the services they need and focus on the most acute needs for both of you. You don't have to go far today, but to look at this ombudsman report, and the number one issue that they deal with every day is services reduced, denied, or terminated. Now, that's not us as a legislature saying that. That's the ombudsman. And this, I see as your report card of what you're doing well and what you're not. This report card says perception or reality that we're denying services or terminating services to patients that thought those services were part of the program. Would you like to respond to that?
Well, I'd first like to say that I think it's an inaccurate characterization to start off. The members' needs are absolutely top of...
So the ombudsman, I'm sorry to interrupt you, the ombudsman report is wrong?
What I'm saying, let me back up. It is an inaccurate representation to have a general statement across the board that says we're not delivering the services. We are delivering the services the members need. It's very important there is a distinction. There are certain circumstances where people are aggrieved by the fact that they believe they need it, but there isn't support for those services. And there's a very small number of individuals when you look at those numbers. And every individual, I would never diminish an individual's concerns. We meet with those individuals to help them understand. We address every single one of those concerns. Their perceptions, their feelings, their thoughts are very important to us. So I would want to be very clear that we are absolutely committed to their needs being met, and it is a needs-driven process.
And I believe you, but I want to make it crystal clear that there's a disconnect somewhere between me, these people, and you, that the services are not being delivered. Whether that's perception or reality is irrelevant at this point in time. What we need to do is a better job providing those services to those patients that thought that they were getting those services. And again, as I stated earlier today, there's one hospital that has 4,000 bed days last year that are still not being reimbursed for. That's not a perception, that's a reality. So that's an example of providers not being paid for the services that are rendered. Next question. Ms. Fultz, you said that you have roughly a little over 20 months of services, and you've got extensive data to show that those services and outcome. Who gets to see that data?
Well, it's data that we share. The state actually has a very extensive reporting structure that they have in place. We produce thousands of reports a year, 1,900 to be exact, 5,700 data exchanges with the state that go about and we transact throughout the year to share that data. And so when we think about that, we look at that data and ensure we're mining that data. We also look very thoroughly every day in regards to our members' needs, ensuring that those services are being delivered. So we have many different data points. Most, if not all of it, is available to the state, and the state, again, very robust reporting requirements.
So I can get that data.
You get the data quarterly, you get the data in an annual report. That data is, again, by all accounts, the most transparent set of data in the country.
So if I wanted to get some
occurs
specific information, specifically like on maybe our LTSS population, and I had some specific questions, both of you could deliver that to me?
we would have to do it through the state. There is privacy laws in place, and so for you to have access yourself to that information, we'd follow the policies in place, both state and federal, that would come through the vehicle of the state, and we would be happy to work with the state to get you any information that you feel you need.
How about a patient?
I can't speak to a patient because that, again, would be subject to privacy laws. And again, all of that would have to come through the state. We are not privy to provide that information directly to you. This is a state program. We would work with the state to ensure that all particular federal and state laws to protect individuals would be in place for any release of information.
The reason I say that, that's their number two complaint that comes from the Ombudsman report, is that there is a lack of access to information or information sharing. So perception or reality, that's another one of those bumps that we need to overcome.
Let me just add to this, because there's a couple of different points. One is, just as Kim has indicated, it is data. We are happy to share the data through the auspice of the state as appropriate. Certainly on a member level, you know, I wouldn't sit here and of course talk about a member, and I know you're not asking that, but any case, any situation that comes in the door, we want to know, we track it down. There isn't one matter that we haven't drilled to the base to figure out and ensure that we are responding, member or provider.
Okay, last question, Mr. Chair, then I'll yield my time. Ms. Foltz, I hear you say this quite often. And coming from private sector business world, it might mean something different to me than it means to you. But I continue to hear this word sustainable. What does sustainable mean? And before you answer that, how much money did your company lose in the state of Iowa last year?
So sustainability, as I've said repeatedly, is important for the health of the program and the health of the individuals it serves. Sustainability means that the state of Iowa understands the services they want delivered and that those services are appropriately funded to ensure that they can be delivered. So the program must have appropriate funding to align with the expectations of the service delivery model. So sustainability is ensuring that long-term, 5 years, 10 years, 20 years from now, there are state dollars available in order to ensure services can be covered for those most vulnerable Iowans. So ensuring that benefits, structures, service delivery is in alignment, it's funded appropriately for the long term. That's what sustainability is.
All right. Well, listening to Representative Forbes here, this is quite frankly, speaking of those rumors and speculations that, not AmeriHealth, I know you, Cynthia, AmeriGroup, for whatever reason, you continue to lose money in our state, and down the road, you decide to pull out. I mean, let's call a fact. United Healthcare probably has the largest checkbook of anybody in the room. You can be sustainable for a long period of time. So you didn't answer my direct question about how much money you lost last year. But I have a good idea.
So to be clear, sustainability, the program must be funded appropriately. We are here to deliver on those services. Managed care works. We have data across the country that demonstrates our performance. It works, but we will not do that and operate at a loss in perpetuity. There is no business, profit or not-for-profit, that can operate in perpetuity at a loss. And so sustainability is important. The funding of the program must align with the program expectations.
So sitting on Health and Human Services Budget Committee, here's my concern. Down the road, you have an issue or you have an issue. You're the only game in town and you come to the Health and Human Services Budget Committee and say the only way that we can sustain this model is for a significant increase in funding if we're going to continue to make this work. That's a concern, that's an issue that I have, and it's one that you better be prepared to answer down the road if it comes up, because you're going to have one very angry legislator if that occurs. Thank you, Mr. Chair. Senator Reagan.
Thank you. Thank you, Mr. Chair.
So you talked a little bit about that you said you saw an increase in emergency room visits. Where's that data?
We have data that tracks our utilization by member. And so that information is threading through. There are certain reports today that the state even calculates and brings forward in the population reports. But when we look in terms of aligning the utilization of the members who are in various programs, we look at the performance of those programs to ensure that they're meeting those expectations. So when I look across the health home programs, we had over 2,000 members that also hit certain algorithms within our data systems that would suggest that the program services, that the individuals were not getting the services that they were actually intended to receive. And so we monitor that very closely. We have individuals that go out and work with those providers, bring that to their attention, and indicate how can we help you to ensure these individuals know there's other places to go rather than an ER, and how do we avoid an inpatient admission.
Right, and that's similar to what integrated health homes do. So my question is, why am I not hearing the same hospitals that there've been an increase in emergency room visits?
So
or was it just United Healthcare's?
We're looking at it population specific. So across the board, when we look at our entire population, the entire population didn't experience an increase. So when we look at the targeted populations and the programs that they're enrolled in, are those programs effective to ensure that those members are getting the services they need? So we track it very closely and work with those providers to ensure they have acknowledgement and understanding.
That's what you just said. So was it United's integrated health homes that were utilizing the emergency room, or all integrated health homes? Because you can't track their data because, right, the privacy issue.
So I'm not certain I understand your question.
So you're telling me, or the committee, that the emergency room visits were on the rise in a certain population, which I'm assuming you mean that's the integrated health home.
Well, first of all, I'm going to correct the statement. What I said was we aren't seeing reductions. So the intent is that we see reductions in emergency room visits, reductions in inpatient, and we are not realizing those reductions. Those are outcomes that offset payments that are structured and intended to wrap the services to avoid those.
So I guess mine would be more anecdotally, because I see the integrated health homes reducing emergency room visits. So mine's more anecdotal. I don't have any data.
And let me just say, there are some that are doing a very good job. Not all 37 are doing a good job. And so there are differentiations. Not all programs are created equally. And so what we're charged with and need to ensure that's happening is those members get the services they need. So when they're not getting them, we are absolutely involving ourselves with that individual to ensure that they're getting the services they need. Again, it is not to our benefit to restrict, deny, limit needed services, because it results often in higher cost care delivery. Our number one goal is to ensure those members get the services that they need.
Right, and I don't think anyone here wants to see increased emergency room visits. I think, and from what I know in my area, the people that have been doing integrated health homes have been greatly reducing it. So some of those did receive notice that they no longer were going to be able to do those services for United. Now,
across the board. I want to be very clear. We are eliminating the services across the board. There are certain individuals. It is very important these relationships stay in place, and so we are committed to that. But we have to ensure that the dollars that are provided to do that service are actually delivering the outcomes. We also have to manage the duplication, and we're driving to a value-based system to drive value and shared savings as opposed to a fee-for-service environment.
So on talking about shared savings and spending, could you tell me a little bit about what the 3.3% will go for? More specifically, the increase that United will be receiving. A little more detail of what that's going to cover.
Well, first and foremost, there's not a 3.3% increase that we receive. So as it nets through, it's not a 3.3% increase. Most importantly, again, the program must be funded appropriately. So it's risk adjusted. There was a general 3.3 across the program increase. Okay. Every MCO has a different population they're serving. It's risk
adjusted.
It's risk adjusted, it's
Right.
balanced out, so it's not across the board.
So you don't have those details here to really talk about.
What's most important is to ensure that the program is funded to deliver the services that is expected of the program. So as you have defined as a legislature what is a covered service, that the program funding is in alignment to ensure the delivery of that service. There are medical cost increases every year. Pharmacy costs alone have far outreached any expectations and assumptions that have been built into any actuarial model across the country. So those types of increases are intended to cover off on increases in the cost to deliver, the actual cost of the service delivery itself. It's not, again, today there's no profits that we can be talking about, so I think it's very important that when we talk about what did transact in the last rating cycle, it was intended to cover expenses that the program was already incurring.
So the emerging trends would be things that you've seen increase in cost. What do you think the providers think? Do you think that maybe they have had some emerging trends in their businesses too? Maybe even administrative costs and refiling, and not, the cash flow issues. They've not received that emerging trends adjustment, so they may not feel as comfortable about that. But I agree, we do see that. So you contract, and there's no conflict of interest. You hire for the CIS scores, you either hire it or do it in-house, and that's not a conflict because it's a different person or a different part of your organization.
That's correct, and they are certified to meet those standards of the national organization, which certifies. There's a quality review process, there's an audit process. It's a very rigorous process to be a certified assessor, and those individuals, again, have a significant amount of audit process that goes in to ensure they meet those expectations.
So do you think it would be better, though, at least to have an appeal process for that for individuals? Just for due process?
So I think from the terms, this is the state of Iowa's program. To the extent that the state of Iowa defines that process, what I would want to make sure that there's full line of sight on is there are expenses that are associated with that process. And so ensuring that the program funding aligns with the expectations will be important.
So in the external quality review, they talked a little bit about the difficulties and the positives. And I noticed the grievance process was one of those that was outstanding for all of the MCOs. Can you tell me a little bit about what IPLR you are doing to change that?
Maybe I can respond. Give you a break. So the ECRO, I'm not sure exactly what you're looking at, the external quality review document. What I think is important to note is that is for the document I'm thinking of, the first 6 months of the program. So it's a new program, new lift. So they come in, do the first level audit, which is a little bit unusual to do it right off the bat, but again, based on Iowa standards, they wanted to hit it hard, so of course we supported that. And then they come back and they tell you some things that, that you need to take a look at. They come back, re-review, and then you hit the standard. In our case, we're near 100% on that, something like 98%, I think, or something in terms of that review. So from a programmatic level for what we have in Iowa, I can't speak to each of, the Emera Health, former or United, but it's pretty darn good. People are good standards.
And one final question. In the state plan amendment, are you sure that integrated health homes isn't a service? I mean, can you show me where it shows it is not a service and it is only administration?
So today, the program is funded completely and solely as administrative. It is incorporated into the administrative load of the MCO's capitation as of 7/1 of this year. So it is defined as administrative to us.
there's some question on it. But thank you for responding to my questions, both of you. Thank you.
Okay, I see that we are out of time, and we don't have one more question. We're just willing to forego that, so we appreciate you coming and answering our questions and talking about your program. Thank you. Okay, now we've come to our time for public comment, and we have a comment sign-up sheet here that we'd ask that you limit your comments to 5 minutes. We have more people signed up than we have time for, but we will take our half an hour. Shelley Chandler.
Good afternoon, I'm Shelley Chandler. I'm the CEO of the Iowa Association of Community Providers. I represent 30,000 employees who support approximately 140,000 Medicaid members across the state of Iowa receiving behavioral health and disability-related services. One thing that's unique about IACP is that the vast majority of our funding comes from Medicaid. We don't receive third-party reimbursement or private pay primarily. I'm going to limit my remarks to the last month. On December 1st, a Friday, there were 4 major systems changes that occurred that affected our providers and the folks that we serve. The first one, obviously, is that AmeriHealth left the state. And as you know, approximately 80% of the providers that we represent were contracted with United, and all of those clients were supported by AmeriHealth. So that was a massive transition. Secondly, the IHH that we've been talking about, and I'll go into more detail on that in just a minute, we didn't know about that change until December 7th. Thirdly, the move to tiered rates for the ID waiver population. And fourthly, within that tiered rate, there was an entire change in how that system was funded to include transportation, which had been brand new. And providers had very little notice of that transition also. So 4 huge transitions occurred on December 1st, again, a Friday. That being said, I want to take just a second to recognize the members of IACP that are here today, because we have lots of people in the room that probably aren't going to be able to speak. So if you just raise your hand to be acknowledged. These folks have come from all over the state to hear what's going on, and we very much appreciate that. With regard to the IHH, we are very happy to have heard late Friday afternoon that United was going to take a pause. We are very concerned about this issue. Over the course of events, IHHs were developed in 2013, and they were really meant to supplement the fact that people with serious mental illness and serious emotional disturbances are dying 25 years younger, because the traditional medical service delivery, including large health systems like ACOs, were not properly treating this population. So IHHs were meant to be a wraparound service 24/7 with clinical peer support staff, as well as service provision. The way that the SPA, this state plan amendment, was developed is that about 25% of those folks involved in IHHs would be those receiving waiver services like children's mental health waiver, rehabilitation, or BHIS, and the remaining 75% of the IHHs would be those without. And that was the way that the rate methodology was developed. So with United taking away 75% of those lower intensity folks, the IHHs that remain in place with that 25% very high intensity, there is no way that they will have the sustainability to continue supporting that service. And my fear is that those members will see significant issues that they saw prior to the delivery of IHH beginning in 2013. We have certainly said with both the MCOs, both AmeriGroup and United, we want to be a partner. We have worked very, very closely with the state and with the MCOs and continue to do so. But having had no notice, in fact being made aware of this a week after the fact that this went into place, is not the way to go about making a massive systems change. This is an extremely vulnerable population, and December is a very difficult time for folks with mental illness. It is a time when we see increased usage in emergency room departments, increase in suicidal ideation and suicidal attempts. That is not the time to make any kind of a huge systems change. I'm going to speak quickly, and I apologize. I want to get as much in as possible. With regard to the tiered rates, there was a lot of conversation about the CISs and providers not paying attention or not appropriately paying attention to those CIS reports that came out. We were not receiving those CIS reports nor the scores. It's very difficult to pay attention to anything that you haven't been given information on, and we continue to struggle with getting those CIS reports and scores in order to determine the level of service we are to provide and how we are supposed to bill. So that is an area of concern. With regard to the certification by a merit group, is my time up?
That's the buzzer.
Oh, all right, well, I will put the remainder of my comments in writing. Thank you.
Thank you. Thank you, Joe. Next on our list is Deb McMahon.
I like fancy machinery, so my name's Deb McMahon. I appreciate the fact you're giving me the opportunity to speak to you. I spoke 2 years ago when they were talking about this privatization, and during that time, I was hopeful that it wouldn't go forward because the Iowa Hospital Association, about every doctor, nurse, every single person in the medical field were against it. As a parent, me too. My daughter Annie, I'm speaking for her today, and my son-in-law Tim. Last time I cried, I said I wouldn't do that today. I hope I don't. I'm going to try not to. There are so many vulnerable Iowans that are affected by this, and it's a terrible, horrible, no good, very bad plan. I need to know when the state leaders, from our governor to state legislators, will stop this charade of pretending that Medicaid works, this privatization. It does not. It is a sham and a shame and promotes a selfish agenda that puts profits over people. I'm here today to appeal to your higher angels. In 2016, Iowa ranked dead last in state psychiatric beds. Not exactly Iowa nice. Our disabled are being treated like statistics instead of the precious souls they are. The elderly languishing in nursing homes, many substandard, have no voice. And we've cut ombudsmen, so certainly their voices have been silenced, and they are counting on all of you to do the right thing. The poor, many of whom are children, are counting on you. They all deserve decent health care. This should not be a partisan issue. Health care is a right, not a privilege. As public servants, it's important to listen to the concerns of your constituents. On a personal note, my Annie had a AmeriHealth Caritas. That was gone. Chose a Mera group. 2 days later, received a letter saying she's with United Healthcare. Now she's been assigned to the original Iowa Medicaid. And I understand from listening this morning, in 3 months or less, she'll be assigned to somebody else. For my daughter and many that are disabled, change is hard. So now she's given from this to this to this to this, and now another change. I think that's unconscionable. I think that should not be. She should know that she has coverage. As her parent, I should know she has coverage, and we aren't going to have a change in case managers, a change in doctors, a change in supportive community. That's not fair to her. And she's blessed because she is covered by Medicare. So 80% of her coverage is Medicare. Medicaid is just 20%. But it still affects us every single day. This is not a smooth transition for her. And I believe privatization has been a mistake. My hope is in 2018, Iowa will finally say and step up, it's enough. Thank you.
Amy Campbell. Or Fiona, or whoever's here. Oh, Flora.
Good afternoon, and thank you for this opportunity. I'm Flora Schmidt. I'm the Executive Director of the Iowa Behavioral Health Association. We represent addiction and substance use providers across the state, community mental health centers, as well as a variety of prevention and treatment programs. This issue is extremely important to us. We appreciate the fact you have brought up a lot of questions already on our behalf. We did submit written comments to you, which I believe you're all very capable of reading and looking at them. So we also have several providers in the room that are the integrated health homes. And with me today to actually provide additional comments for us is Chris Ritchie with Crossroads Behavioral Health down in the Creston area.
Hello, thank you for letting me the opportunity to speak. I wanted to talk to you today about the integrated health homes. And our focus is ensuring that our members are not falling through the cracks. I can't say that we win every day, but we try the best that we can. And how do we do that? We serve members who are considered to be low intensity. So we've heard about the HAB and the Children's Mental Health Waiver, who will continue with IHHs under United's model moving forward. But what we're missing is those low intensity members. And why do we serve those low intensity members? Because they're on the cracks. They're either not ready for 24-hour services or a provider to come in, or they're working their way out of that service. And so we're a very fluid agency. It's built up by the peer support, the case manager, and then the nurse that provides that support. Many of these individuals that we work with on a daily basis have exhausted community supports. They have nowhere else to turn to. IHHs take the time to do the things that no one else will do. We fill out Social Security applications. We go with someone to HUD to fill out the paperwork. Who else does that? I mean, I would say that's the common denominator of, and we help with transportation. People say nobody else helps me do this that you guys are willing to do. Here is why we need the IHHs. We have contracts with all the MCOs and the fee-for-service members. We have many of the MCOs we found have come and go somewhat quickly. Our members deserve to have a provider with a non-anxious presence to help them weather through the storms that we go through with the Medicaid services. A consistent voice or person or agency that they can turn to when their life gets mixed up. Their Medicaid paperwork went to the wrong address. How do I get that fixed? That's what we're here for. I had a member call me the 1st of December, and they had an AmeriGroup card, they had a fee-for-service card, and they had a United card. They had a doctor's appointment December 3rd. Which one do I use? We had to call the Else line to find out which one that they use. Just kind of another example. We had a member coming out of PMIC. They'd been about 60 days out. That mother called us on December 6th, and she was needing some help because things weren't going so well as she returned home. Well, that person didn't make the list. So what do we tell that member? Sorry, you aren't on our list this month. We can't help you. I mean, that's kind of what happened with it. We didn't do that. We are committed to serving the people that we have signed up to serve. We want the same commitment from the MCOs as well. Our focus is improving outcomes, relies heavily on relationship building. And you can't build relationships without trust and lack of transparency. How are providers expected to operate as a business when we are unable to receive accurate information? How can you build trust and a relationship when you don't know what your membership list is going to be from month to month? I mean, that list doesn't come out to the 7th. A lot transpires between day 1 and the 7th of the month. We want to continue to be the consistent source of truth for our members. And that's...
I'd just like to add to the committee is we're not a standalone organization. We have worked collectively, not only on just this issue, but several others. We've been working with Shelley Chandler and IACP. We've been in conversations with the hospitals, several of who are also members of our organization, and some of who are ACO, accredited with United Healthcare, and they're telling us what we've told you in our letters. They're not ready to take this population over. They were not anticipating it, and we just hope you'll give sincere consideration to the population. Thank you for your time.
Okay, Dusty Markey.
Hi, my name is Dusty Markey. I'm a certified peer support specialist for a local IHH in the area. I am here, as many of the people in this room are today, to advocate for the clients we serve. At the IHH model, we serve to encompass full body health holistically, with an emphasis on mental health. We serve two different types of clients, those who receive rehabilitation and those who do not. Clients who do not receive rehabilitation are either not eligible, lack self-directing skills such as self-control, follow through, and making healthy life choices, or they have made a personal decision just not to participate in rehabilitation, because in the end it is their choice to do so. 4.5 years ago, when I became a peer support specialist, I was qualified and available to service both clients who received rehabilitation as well as clients who did not. Just over a year ago, this changed, and the services I had been providing to HAB clients were no longer billable unless I had a bachelor's degree. Since then, I have been working primarily with non-rehabilitation clients. I would like to draw focus to them. Please hear me when I say that just because these clients do not receive rehabilitation, it does not mean their needs are any less important or as intense as those who do receive rehabilitation. This is why I'm here speaking today on their behalf, so that there is no decrease in services for them. The services provided to non-rehabilitation clients are very similar to those who do receive rehabilitation services. I will not mention a few, or I will not mention all of them, but I will mention a few. Mentoring, preventing loss and benefits by assisting with paperwork, assisting in communicating with mental and physical health providers, coordinating as well as facilitating access to community resources such as food banks, agencies that assist with financial assistance, as those that we work with have limited to no income, standing with them in court, attending important meetings, advocating for housing for our hard-to-place clients, providing groups for fun and support, as well as a shoulder to cry on the days when they're just too hard. Those are just a few reasons why the IHH services are so vital to those that we serve. I would also like to highlight that even if these clients were eligible or wanted to participate in rehabilitation, they could be on a waiting list as long as 9 months, as most agencies have closed or let go of staff due to MCOs not paying. In the meantime, while clients are waiting for a provider to be available, it is the IHH staff who provides these services without reimbursement, in addition to our normal job duties. What United Healthcare is proposing of taking all the non-intense clients away from an IHH will strip vital services from thousands of non-IHH clients in need of IHH services. UHC is attempting to take the choice of selecting a provider directly out of the hands of the client and putting it directly in their own. This is stripping and taking away clients' rights, dignity, and peace of mind. Since the MCOs have taken over managing services, what is or is not cost effective in the eyes of the MCO has taken priority, not the person and the services that they seriously need. When the payer of the service is also the provider of the services, there is a serious conflict of interest, and the clients will ultimately suffer. It is probable that there will be an increase in ER, urgent care visits, and hospitalizations for our non-rehabilitation clients, as the proposed replacement of services provided currently by the IHH will decrease in the hands of the individuals trying to cut costs versus caring for the person and the services they need. Each and every one of our clients deserves and is entitled to choose who they receive their services from, whether it be UHC, AmeriGroup, as the managing care, or the IHH. I have seen many clients within the IHH make great progress. Myself included, even as an employee, I've grown immensely in 4.5 years by just working and learning from the people that I had to engage with. I ask that we please let this continue to be the case. Thank you.
Thank you. Steve Roberts.
He's not on the list of things.
All right, we'll take him off. Lori Bush. Thank you.
My name is Lori Bush, and I'm the director of the Integrated Health Home at Plains Area Mental Health Center located in Northwest Iowa. We're a rural IHH serving nearly 1,300 members in about a 10-county area. I would like to express concern of the recent change of the managed care organization eliminating the choice of IHH service for approximately 300 of the members that we serve in our IHH. The mandate in the state of Iowa has been to provide member choice and person-centered care. The recent change has not given this population either of those. The managed care organization has stated that the IHH is not a service, but rather an administrative function. I assure you the work goes far beyond administration. IHH is a mobile, boots-on-the-ground team of professionals who work with members in their home, in the community, in an office setting. They meet the members where they want to be met. The team assists members in identifying needs prior to the escalation of need that results in high cost of care. The mobile part of the program is what I believe has led to much of the success and the outcomes with our population. Because IHH sees a person in their environment, we see the needs such as housing, nutrition, social isolation, transportation, mental health symptom exacerbation, etc., and refer members to resources prior to the escalation of need. That's what prevents higher level of care. IHHs have served members since 2013 with tremendous outcomes. Magellan began the oversight of the IHHs and provided statistics in 2015 demonstrating proven results, including 16% reduction in emergency room department visits, 18% reduction in inpatient mental health hospitalizations. With implementation of the managed care organizations, the good work of the IHH has continued. I don't have data from the state of Iowa, but I do have initial report cards from both AmeriGroup and AmeriHealth for our IHH program, which indicate that we specifically met the HEDIS measure standards for ED visits and hospitalizations within our integrated health home. 300 of those members are the ones that United has no longer had enrolled in our IHH program. We have spent the last 3.5 years building relationships in the community, creating MOUs, business agreements, and signing releases of information that have allowed us to build relationships in the community and have those important conversations with the other providers in the communities that lead to improved outcomes for our members. We've established care compacts with hospitals and PCPs. We have actually a letter to submit that shows their support for our program. One of the initial outcomes we had through that agreement for a member who worked with a specific hospital prior to IHH enrollment had 37 ED visits in 1 year. With about a $1,200 estimated cost of an ED visit, that equals about $44,000 in 1 year. After enrolling with our IHH, the first year those ED visits were reduced to 16 in 1 year, with that average cost of about $19,000 to the state. The next year, only 4, with the cost of about $4,800. Total cost for IHH services each year was $964.68. That one member, through the work of the IHH, saved the state about $62,000. We have a lot more stories we could share that demonstrate the same outcome. Other outcomes beyond ED visits and hospitalizations, including increased school attendance, employment, and other areas. We have great concern about removing the choice of IHH services for the persons that we serve. Another concern has been that lack of communication by this change of the IHH services to the members affected, as well as to the IHHs affected. Many Medicaid members are confused, they're scared their services are being eliminated, and they don't understand what's happening. IHHs are in limbo at this point regarding continuation of the IHH work. How do you serve members you're not getting paid to serve? How do you let them not be served? We respectfully request the change that's been implemented be reconsidered, and at minimum, a well-informed and communicated transition plan be implemented with sufficient notice to members and IHHs across the state. Thank you.
Thank you, and I believe we'll take time for one more. Shauna Freitag.
German, not German.
Okay.
Yeah. Good afternoon, and thank you for this opportunity. I'm Shauna Freitag, Executive Director at Young House Family Services. We are a small social service organization in Southeast Iowa. We serve approximately 4,000 children and their families each year. We also have a pediatric integrated health home program. On Thursday, December 7th, our organization received an unanticipated call from a United Healthcare representative. The representative explained to our Integrated Health Home Program Director that she was directed to read us a statement over the phone. That statement identified that more than 100 of the children who previously were served through AmeriHealth would no longer be receiving integrated health home services through our organization. According to the representative, this decision was effective December 1st, and those previous AmeriHealth clients would now receive their case coordination through their ACO or primary care physician. When our program director attempted to ask for clarifications and questions about being reimbursed for the services we had already provided, and the future of our integrated health home services with United, they told us that they were directed to reread us this statement. Every time we asked another question, we were again reread the phone statement. As of December 15th, our organization had yet to receive anything in writing from United Healthcare or the state of Iowa in regards to the sudden and shocking news shared with us via a phone conversation. As the executive director, I have made numerous attempts to ask questions from United about payments of services, the mere future of our integrated health home programs, and more importantly, how our children and families will be notified of this decision. When are our families going to find out that they no longer have a nurse, a case coordinator, or a peer support person available to them, advocating for them, and helping them coordinate services locally? Additionally, I have several staff members wondering if, based off that phone call and verbal statement, whether they're going to lose their job 2 weeks before Christmas or shortly after. Today, I ask the state and United Healthcare to seriously consider the impact such a phone call has on providers, children, and their families. As a provider, the decision has had a major impact, or will have a major impact, on our small rural organization. The unenrollment of nearly 100 AmeriHealth children from our pediatric integrated health home program will result in $124,000 in lost funding. On behalf of child welfare providers across the state and children and families served through our pediatric integrated health program, I ask the decision to suddenly cut integrated health home services be reconsidered. At minimum, please properly notify providers, children, and their families of changes to their services in advance, with transparency, and in writing. Furthermore, in response to some of the comments that were made previously today, I would like to make it clear that our IHH program has had exceptional results for children and families. We have yet to be informed by any MCO that we are, quote, out of compliance, nor have we been informed that we are not meeting or fulfilling the expectations of our contract. Instead, we are attending school staffings, we are coordinated for services, getting kids beds, ridding homes of bed bugs. IHH is so much more than just an appointment or a call center. IHH is not administrative functions. Thank you again for the opportunity to speak and for your time today.
I want to thank everyone who was able to come up and share with us. I want you to know that I took some notes and I'll be asking some questions, as I'm sure others of the committee as well. So now we're going to take some time as a committee to discuss, make any comments or discussion that we have. So, Senator Mathis, I guess I'll let you speak first.
Yes. I just wanted, pertaining to this last section, that I wanted to also add written communication with permission by each of these people from Kelsey Holland with Crossroads Behavioral Health, from Lisa Dix from Crossroads, from Marcia Oltraggy, who is with the Executive Director of the Northeast Iowa Mental Health Center, also from Laura Scholl from Crossroads, Chris Hoffman, also from Pathways, Clint Brown from Crossroads, also Tom Yukas, the Executive Director of Unity Point Health, Black Hawk Rundy Mental Health Center, from Leon Kishman, who's with Families First Counseling Services, from Dan Strelner, who is the president of Abbey Health, from John Tortis, who is the president and CEO of LSI, from Melissa Ahrens, who is with Community Support Advocates, from Natalie Milbourne, who is a concerned family member. It was to all of us. Also from Audrey Larson from the Siouxland Mental Health Center, from Billy Butler, an integrated health program manager from the Southwest Iowa Mental Health Center, from Kathy Johnson, also from Abbey Mental Health Center in Cedar Rapids. She will be the incoming president and CEO. She's the executive director there now. From Paula Rezel, she's the mother of 3 sons, and 2 of her sons have been diagnosed with serious mental illness. And then from Faith Hausman, Hillcrest Family Services Integrated Health Home. She's the Southeast Region Program Manager. I'd like to enter these into the meeting minutes as well as part of written testimony.
Thank you, Senator Mathis. Just a question. Would you characterize these as mostly about the integrated health homes?
Yes, it is. It's their concern about mainly that integrated health homes is considered holistic from their point of view. They were, I think from our last testimony, they were quite surprised that this was going to be blown up basically. It was one of those services that they felt, actually was working and they were actually getting paid for it most of the time. So yeah, by and large, that's it. And their concern about mental health care when across the state what we're hearing is, what are we doing about mental health care? What are we doing about mental health? And this is something that they felt was making a difference.
Okay, thank you. Are there any other comments from the committee? We don't have to take this time if we don't have anything to bring up. We'll go Senator Sager.
He doesn't have much time to talk time.
I was simply pointing out that Senator Sagebart was trying to get his attention. I don't think he see it. So that's why I was
Just came quick this time.
I'm often overlooked over the corner, but that's okay. Listening to the discussion, I appreciate everybody's statements today. And I can only go back to the point that Representative Taylor was making about expectations. What were the expectations when the governor decided that this was the place to go? None of us have seen that. I think we all assumed the expectation was mental health and Department of DHS was burning up too much money too quickly, and that part of the budget was growing so fast that we weren't going to be able to sustain that growth. I've never seen that written anywhere, but what we should have probably done a long time ago is put forth our own expectations where we think this should go. And so I would just make a recommendation that, and I don't know that this committee has the funds or the power to do this, but to establish a committee to come up with their own set of expectations. Now this has got to be kind of a broad stroke because that document would be this thick and you wouldn't be able to manhandle it. But I think we need to work on what our own expectations are, and they need to know what our expectations are for them to make progress and where they're headed, because without that, they just kind of work on it one problem at a time. So that's my proposal to the committee.
I'd second that. Well, I think
Go ahead.
usually with interim committees, we come up with recommendations, and I think that's a good start to be reevaluating the program. I think we've seen some real concerns. Today it was integrated health homes. We've seen certainly, the list. We get the emails, we get the information from many folks, and I think that this is a good motion. I think it's a good idea to talk about, and I think a recommendation to study what we really are expecting. It was not really that the legislature was included when it was determined to begin with, so I think this would be a good use of our time.
Representative Fry. So I'm going to try and take notes of what I'm hearing as recommendations, because if we don't have somebody doing that, we're going to get to the end of this half hour with not. You're taking the recommendations as you hear them? All right. One of the other pieces that I would add to the discussion would be, I appreciate the fact that the department and the MCOs, specifically United, are extending this IHH conversation to the end of January. I would like to have emphasis added to we need to study the effects of that on the state so we have a better clarity as to where we are headed with elimination or transition or what that looks like. So I would offer a recommendation as it relates to emphasis on the IHH.
Okay, Senator Sheldon.
Thank you, Mr. Chair. I look at this process that we're in right now, and I'm trying to understand historically where we came from. And I think it's a legitimate question to say that the governor's office made this decision because trying to change the cost curve. Whether or not the existing cost curve at the time that the decision was made was going to put us in a position where we couldn't afford to provide services for those who truly need it. I know that the legislature spent their time at that point budgeting based on the new expectations of cost savings going to an MCO project. But I think what we've missed in this process is what I heard earlier from the department, which is standard business practices. Standard business practices means that when you provide a product, when you provide a service, you're paid in a timely manner. If you fulfill your half of the agreement, the other half of the agreement is fulfilled in a timely manner. That's on the payment side. I'm really bothered that a change after the fact to a service was done by a phone call with no expectation of why that change was made. If they are extending that process past the dates, great. But I don't know of any business model out there where you would take your partners and you would treat them that way. This is a serious issue in my concern. First and foremost, I agree with this committee that we need to be looking after the individuals that utilize the services as our primary issue. But coming right behind that is the people who provide those services and whether or not they are being treated in a professional business-like manner. And if they're not being treated in a professional business-like manner, I believe it's incumbent upon us to step in and start defining what that means. What that means in payment, what that means in expectation, what that means in how you treat another business in the state of Iowa. It wasn't too long ago that Iowa had one of the best healthcare systems in the entire country. We still had complaints, people still complained about the process, but it was a very good system. And in a short time, we still might be one of the best, but we're nowhere near what we used to be. I would appeal to my colleagues from the other party at this point also. I truly believe there are a lot of people in the state of Iowa who need us. And we need to make sure that we prioritize their needs first and foremost. And if we keep talking about this healthcare as a right, that everyone deserves healthcare, pretty soon we can't take care of those who truly need it. We do have to have, and I am a supporter of a CIS type of score. I think we should do it for all healthcare. I think we should say, listen, this individual is relatively healthy, they're relatively capable. Therefore, the dependence upon a taxpayer should be less versus someone else who, by no fault of their own, has had these issues. They were born with a disability, their family struggled to make sure they're taken care of. They should be prioritized higher as far as how much money the taxpayers invest, the state of Iowa invests in them. When we open the doors up and say, everybody jump on board, eventually those who are truly in need start getting squeezed out of their basic needs. I think we need to be really careful in that process because I have no problem helping those who truly need. I had a conversation actually with Senator Yoakum about it a while ago. And the simple statement was this, which is, I think every legislator in the state of Iowa agrees there are those individuals who need it. We only question what that threshold is. Is it 10, 15% of the population, or is it 50% of the population? Because at a certain point, we're out of money. I want to make sure that the money we do have is focused on the individuals who have the highest needs. Thank you.
Representative Taylor, I believe you had your name down first.
Thank you, Mr. Chairman. Thank you for everybody for our very robust meeting today. And I know the courage it takes to stand up and sit down in front of a committee and testify. So for those of you that did that today, thank you, and my heart goes out to you. I'll just wrap mine up in 3 quick points. Number 1, we need to put the patient first again. We're all wrapped up right now of how we're going to get paid, when we're going to get paid, who's going to pay them, and God help us, by the way, if we're the government and we're to help, because I think that we've been a picture-perfect example of how government can interfere with a fairly streamlined process. So first, we need to put the patient first. We also need to remember that when it comes to Medicaid, Medicaid was originally designed for our poorest and most destitute in our population. Ironically enough, these are the people that for whatever reason we can't help right now, and that's unacceptable. Finally, Senator Sagabart, expectations, here's my expectations. That patients get the services they were originally promised, and that providers get paid promptly and adequately for the services that were rendered. Thank you.
Senator Mathis.
Wow. This is music to my ears. Senator Shelburne, you know, I couldn't agree more with you when you were talking about providers not being treated fairly. From the very first day that they were offered contracts to sign that had nothing in them, April of 2016, yeah, that's not a way to do business. So yeah, I'd say looking in the Wayback Clock or listening to the Wayback Clock or looking at it, whatever you want to say. Yeah, we need to start making some changes here. And I think if we're at this point, and Senator Siebert, thank you for bringing this forward. You know, if we're at this point, I think we need to also talk about how we can, as we still move forward, patient-centered services. As we're moving forward, we look at how we can redesign some parts of this that are more customized to the state of Iowa and less templated to systems across the rest of the country. I would like to say that we could certainly hybrid some of this because some states have done that. A number of states have taken managed care and fee-for-service and combined some different approaches. I know the governor's office has said that they're very concerned about the waiver community costing more and more every year. But I think that if you talk to Shelley Chandler and her group of providers, they would probably be the first group that would sit down and say, these are the things that the patient needs the most. This over here, we could probably cut, or we could revise, or we could do something differently. But the problem with this approach, the problem with this model is that we've never asked them. They've never been part of the discussion of this design, and that's flawed. That's flawed. So hopefully, when we get down to making a recommendation here at the end, it might include health homes, very definitely, but look a little broader at if we are going to sustain this, and if it is going to be for Iowa, for Iowans, that we consider redesigning some parts of this, and that we roll up our sleeves and we get to work.
I guess I'm going to say it's a tie, but senators win because I'm a senator, Senator Reagan.
I think I'd like some clarification on what we're going to do to help the integrated health homes. They're kind of up in the air yet as we leave here with January 31st. If I'm running a business and I don't know if I'm going to be there after January 31st, how am I going to keep employees? I mean, we're talking, you know, holiday season, but beyond that, they don't know what's going to happen, and I think we need to leave with a recommendation on that before we leave here with moving with that. I think your idea is great to work on some structural changes. You know, I'm ready to go back to fee-for-service and make a huge change on that. But I think now we have some opportunities. We've all heard it. I think we're pretty much in agreement that, you know, patient first, Medicaid for the most vulnerable here. When patient gets services and paid your providers adequately. But right now those are things to work on with your position. But I think now we have to say something about the integrated health homes, because January 31st is going to be here sooner than we think, and we are not going to be able to move on it unless we do something here with a recommendation, whether it's a letter, whether it's something to Director Foxhoven. I think that we need something today.
Lisa, or Representative Hedden.
That's fine, I am Lisa, so thank you, Mr. Chair. You know, I guess my comments similar to what Senator Reagan had in regards to the integrated health homes. I mean, bringing it up here as to what does happen by January 30th, that is problematic for them, for the providers and for families to know what's going on. Senator Segerbart, I thank you for bringing your suggestion forward. You know, we've heard in previous conversations, whether it's been before this committee or during session through the Health and Human Services budget, that there are some positive aspects to managed care. But the people we hear the loudest from is where the problems are. And they've been speaking very loudly for quite some time. And it's the similar type of issues that we're hearing. Again, that denial, termination, or reduction in service are probably the main things that I continue to hear, or that providers are not getting paid. The lack of communication is significant. The fact that the Department of Human Services, when they heard about what was going on with the integrated health homes, or the fact that providers, when they heard, or that the family members did not hear at all. You know, you get to a point where you have to legislate the managed care companies to actually speak to people. And that's not where I would like us to see, but I feel like that's almost the direction we need to go to. So, you know, I do think there's a lot of things that we can do. I too would be a proponent to go back to fee-for-service. You can certainly make that work well and put some greater parameters in there and oversight and move forward on that, because certainly providers got paid. And I certainly was not hearing from the volumes of people that I hear weekly that are getting cut or reduced in services. And so that says something to me of what's going on these last, 16, 18 months or so. Thank you.
Representative Forbes.
Thank you, Mr. Chairman. Serving on the Budget Subcommittee for the past 5 years, went through a lot of these meetings and processes, and 3 years ago right now is when the governor basically was coming out with his proposal to move to a managed care system. At that time in Iowa, I thought, as Senator Shelton had mentioned, had a fairly well-run Medicaid program. I think in some cases we were considered a model for other states around the country. And in one swipe of the pen, we dismantled our system overnight. And as you can recall, we sat through the budget hearings and listened to consultants from around the Midwest here saying, you know, it can be done, but it's a pretty aggressive schedule. And January 1st of 16 rolls around, we're not ready to start. March 1st rolls around, another deadline, we're not ready to start. Finally, April 1st rolls around to last year in 2016, we start the program. And it starts out very rocky. Now, I'm the type of person, I like to give people a good, honest chance to be successful. You know, 6 months in, we were having problems. I thought, well, okay, these are growing pains. 12 months in, still having problems. And here we are 20 months into the program, we're still sitting here talking about all the problems, and they seem to be getting worse and better. We shouldn't even be sitting here today. We had to form this committee because the MCOs were not performing their duties that we had asked them to perform when those contracts were initiated back in April of 2016. In my practice as a pharmacist, I see patients on a daily basis who are affected by what we have done. I literally probably spend 5 to 10 hours a month in my office talking on the phone, visiting in person with family members, recipients of Medicaid services that are very, very upset. In some cases, tears are shed because I hear some of the terrible stories that are being done by the systems that are in place here in the state of Iowa. So with that, I said, we have to do something. We have to make a change. It's not working. I mean, I'm probably as close to it as anybody in this room, being a Medicaid provider for the last 37 years. And so, over the summer, I worked with Senator Matt McCoy. We held forums here in Des Moines, 2 forums, to bring in people from Central Iowa to get their input on what we need to do to shore up our state Medicaid program. We listened. We had probably about 100 people at each forum. And we decided that we needed to address this problem. The other issue in the state of Iowa is affordable health insurance for people that are not on Medicaid. As you know, in about 13 days, there's only going to be one commercial insurance program for Iowans, and there's about roughly 70,000 people affected by that. Now about 30 or 40 or maybe 50,000 are going to get subsidies from the federal government through the ACA. So a bill that I'm going to introduce tomorrow will take us back to our fee-for-service program here in the state of Iowa. It will also allow for a public option, people to be able to buy in to our state Medicaid program if they would so choose. And I know it's probably an uphill battle, but we're trying to put forward a solution to this problem. A problem that affects 560,000 Iowans at minimum. And I know, unfortunately, some people have literally died from the transition from a fee-for-service program here in the state of Iowa to a managed care system. So I would ask the committee to seriously consider all these ideas when we move forward in our legislative session next year.
Senator Shelter.
Thank you, Mr. Chair, for a second time. Representative Forbes, thank you. By the way, I like the concept you're bringing forward. I did try to do the same thing by putting legislators on Medicaid, figuring that would improve the system. I was told that was not going to be approved by CMS and not approved at the federal level. So if you can figure out a way for people to buy into the Medicaid system that will be approved at the federal level, please let me know, because I'd like to include legislators in that. That being said, I do have one thing I would like to ask that we include in this. This room is a room that I meet on a regular basis on for rules. There are certain things that the Rules Review Committee can do that most committees can't, but I will ask that we maybe put it into our process if we can agree on that. And that is asking for IHH process to be delayed by 90 days. So they can give us till the end of March for the legislature itself to have some time to weigh in on what that process would look like, making sure that there's transition times for these individual businesses. That's one of the things I would request from this committee, to ask for that 90-day delay so that we can review it, not just for this committee itself, but for our colleagues that are not in session yet. I think that's an important aspect, that it shouldn't just be a subset of the legislature that makes some of these hard decisions. We're making a recommendation to the legislature, but I think that we may want to make that recommendation along with a request. We can't obviously enforce it, but a request for a delay of implementation of that process for IHH. Thank you.
Okay, that's all I've got. I've got a few comments I'd like to make, and we're speaking to the recommendation for the IHH thing. One thing I think we should maybe say is we need the providers and the members to be notified at least 30 days in advance so that everybody can plan how many people we have, who's going to be needing the care, and making that transition. I think that's very important. Pardon me?
And in writing.
In writing.
Yes, and not just calling. A phone call seems not the way to go about it, to have something go out in writing to the providers and the members. I think that would be a common sense recommendation we could all probably get behind. Another comment I'd like to make, I want to welcome our Medicaid director. He's new here. I have some hopes that he will be able to help us work through these problems we have and make it a little bit less bumpy road. I guess I'd want to say, Director Randall, I have high expectations for you and what you can do to help us with your experience and leadership. And so I just wanted to make that comment, that I'd like to give him a little bit of time to make things work better, and I'm optimistic that will help. So with that, I would entertain a motion to adjourn. Or do you have more comments?
Don't we have to kind of move forward and all agree on what we're presenting? Possibly there's a recommendation about the Rules Committee, the 30 days in advance. Do we need to make it more formal than that?
I don't know what we do. I'm not sure what we have a motion we can put before us, but we can maybe talk about it together and see if we can't come up with something that we would, as a, via email or whatever, we can come up with something we would like to, that we could all sign off to it after this meeting. But
if I could add the floor for a second.
Go ahead, Mark.
My proposal is to have a committee that could sit down and kind of put a document together that we could maybe move on early in the session. I don't know if that's possible, but I suppose it is, since it meets every morning during the first month of session. This committee would probably approve a document that puts out expectations, which the first bullet point would be IHH is not an administrative thing, but it is a right word here.
Service.
It's a service.
Okay. Well, Senator Representative, if I want to.
My only comment is, when I go back to our original rules, whatever recommendations we put forth go to the Legislative Council of General Assembly. That's where we have to send whatever document we produce out of this committee. We can certainly suggest another committee be made. We can't authorize a committee to be made to look at what you're looking at, but we could suggest that the Legislative Council look at creating a committee to do that what you've said. We can suggest that we delay implementation of IHH. Why can't I get that out today? I apologize, folks. We can certainly suggest that. And there was a third factor in here that I heard, which was, I believe, Senator Mathis, yours on some sort of a study or idea related to what we can keep, what we can move forward with, what we can integrate, what we can utilize from the system. I hear some say back to fee-for-service. I think that may be backwards from where we're at, and that really upsets the apple cart. How do we move forward in a way that promotes the best health for everybody in the state of Iowa? So those are the three big recommendations that I heard the committee make. I'm sorry, I'm not chairing.
Oh, please.
Representative Taylor
If
would
you're
like to
done,
speak.
if you're done, let Representative Taylor.
I've said enough today, it probably got muddled up, but don't forget that we have a situation going on with rehabilitation right now in which the tiered rate system, they're kind of falling through the cracks right now on the reimbursement, and there's a number of those out there, so I'd like to at least address that in some sort of a comment as a recommendation.
I thought it was interesting that that hadn't been brought up, and we all know about it, so thank you for bringing that up.
Details matter.
I think incinerating.
I think it's for more than just for all of the whole CIS process. I think would be good to evaluate to see where it's at. And so we have a better understanding of who's evaluating and what the appeal process is. And at this point, I don't think there is much of an appeal process. And so if we could have clarification on that, that would be good. And to Senator Segabart's motion, I think he could set up a human resources committee and work through that. If that would be helpful. He's got the power to call a committee meeting the first week. I'm sure that we'd be more than happy to meet on that subject.
And the House would join them.
Well, that's a little iffy.
Okay, are there any other committee members that I think we can go forward with that? Is that okay? All right.
So can I have Patty repeat what she heard?
Okay, I think that'd be a good idea.
Microphone's on.
Okay, well, I mean, and anybody else jump in here. I think one of your big issues is IHH and just where that goes, and looking at that and delaying potentially through rules or somewhere any move forward on that until everyone's clear on what's happening with these communicated things. I have, establishing some kind of a committee to look at all of these issues, including and probably reviewing DAHAB and the whole CIS process to make sure where all of that's going, and that there is some kind of a way for people to either appeal or be reevaluated. I think that's,
Patty,
I don't know, what else do you want?
if I may clarify that,
Please.
regardless of if there's a separate committee formed or not, those are issues that need to be addressed.
That's
I think the overall thing is maybe have an ongoing kind of a subcommittee or something where people looking at stuff, like if you have the IHH and the CIS and the DAHAB, those seem to be kind of
To study the broader look at this, as Joel was reciting, just the broader look at what's working and what's not.
Okay.
Whether we hybrid, looking at a hybrid system or whatever it might be.
And as the notification process, and I think that's kind of part of the whole, the overall, part of what the IHH process would be, and I did a really poor job, sorry.
So I would make the motion based off what Patty has in her notes, if that's what we would move forward with recommendations out of this committee. Oh, wait a minute, she's going to add something.
No, what I'd like to do is, if I can, I'll write something up and send it out to all of you and make sure I've gotten everything the way you want it.
Good. And then do we vote by proxy? What do we do?
I think we all just say yes.
Just say yes.
That's what they usually do with it.
We've never gotten this far before.
So we really don't know. Oh, we have.
We
You
have.
just haven't been here when we have.
It's his problem.
Okay, I'll take it.
Okay, anything else for the good of the cause? All right, I entertain motion. Senator Sheldon, moves to your right.
Well, let's do Merry Christmas, everyone.
Thank you.
Let me know my journey.
That was on the
You have your thing taken.
We do have to do it.
The only thing that might work with you if I go, I'll write that up. I'd have to really raise your pay. I'm glad she's coming back. God really
Yeah, I got it. Yeah. I'm always on this. That's what? All right, here's your curls. Well, good. You got all the staff here. I will go. Come on in. Water stop. I'm just saying. Okay, thank you. Just saying. Okay, yeah, she passed down, but I didn't read it, so this, yeah, I'm gonna, well, that's from San Francisco. Oh, yeah, that's what they do, but maybe take those two, and make sure you got it. Then you said, oh, are they? They may not be. You got them. And then there was a link. Well, one of them was she specifically said it's only a small number of general concept that what they said.
It was in regards to the ombudsman report that said, the number one issue that I have is services.
Okay, and that was that for sure. Okay, that's
yeah. I think so. Yeah,
the ombudsman is wrong. Right, and I have all that. Okay, good.
There's something, you probably have to walk up to it in that middle, because I think there's something to push. I push this. It's blinking red. Does that mean it was out of tape? Or
no, it's still taping, but where does anybody know how to, I don't know, because this, there's this button here, but I'm not sure what that does. Thank you for climbing over the table. I know. I know there's like a button on the back or something that I then said just shut. Like this one, you think off? No. Changes it.
Does it look like it's on now when you look at it?
No, it's on. Can we just unplug? I don't know if that would work. Oh, here, on this? Is it on this? Oh, here. Oh, wait, what's this? Is this the on-off right here? No, do not.
Well, that little counter, is that the counter? Because it's not moving anymore.
It's taping away.
But that little thing down there, that doesn't mean how many, maybe it did just.
No. What about here? What if I shut this off? Will that shut it off? Should I try it? It might shut off the live stream. That's what I need.